Okay, good morning, everyone. Thank you for being here. Thank you for joining NBHP for our February continuing education training. My name is Sydney Carter. I'm the Ready Program Manager at NBHP, and I also do our continuing education events each month. So for today's training, I'm really excited to have our sleep disorders and behavioral interventions training with Jessica Fink, who is an LCSWS based in Austin, Texas. She has 18 years of experience in the mental health field. She works at a psychiatric hospital for 14 years and has also, or at the psychiatric hospital, she worked in inpatient and intensive outpatient settings. In 2021, she transitioned to a full-time private practice and specializes in sleep, chronic pain, OCD, PTSD, and RODBT. She considers herself a therapist for the rule followers. She favors structure, evidence-based approaches with clear goals and agendas. And outside of her clinical work, she enjoys immersing herself in the world of theater, watching reruns of Golden Girls, and rocking out to 90s alternative rock. An avid traveler, she has a personal goal of visiting all 50 states and all 7 continents in her lifetime, intending to learn something new in each place she visits. So I love that. I resonate with a lot of that. I love to travel as well, and have one more continent left to visit. So we'll have to chat
Oh,
about that. Yeah.
cool. Cool.
Yes. But so I will also give a little explanation for our CEUs. So everyone joining by 9:15 a.m. and staying for the duration, as well as keeping tabs on the CEU survey that I will put in the chat at the end of our time. You'll be eligible for 3 hours of CEU credit. So this is a bigger one for us today, which is great. And so join by 9:15, stay for the duration, take the survey. You'll be eligible for 3 hours of credit. We are recording this training and it will be shared with participants after, as well as the slides. So you will have the slides, you will have the recording after. And without further ado, please feel free to introduce yourselves in the chat, turn on your cameras if you'd like, and stay on mute unless our presenter asks us to come off. And then I'll make sure that the questions are answered in the chat, maybe at the end or when there's a pause. We're also going to have a break in between, so that will come up in this 3 hour training. So you can kind of have that on your mind. But yes, I'll pass it over to Jessica. Thank you all.
All right. Good morning, everybody. Glad y'all are here. And yeah, it looks like I've got a fellow RODBT. I was like, oh, somebody knows what that is. All right. So I am going to share. All right. And then let me put this in present so it looks better. Okay. So I wanted to talk to you guys today about just all of the different ways that basically what can non-physicians do to work with people who are having trouble sleeping. And it turns out there's actually a lot. I think there's this misconception that sleep is medical, that you always need a sleep study, that you always need a physician, that there's nothing that therapists can do to help people with their sleep. And that's actually not true. And so that's kind of what we're going to talk through today. So here's kind of the outline. So these are not like three equally. Like the third section is going to be like the media section. But we're going to start out going over, and this is all the same psychoeducation that I give to all of my sleep clients in our first session or first few sessions, is the biology of sleep. And what are all the different factors? What's happening when you're sleeping? What are all the different factors that impact someone's sleep? There's something called the two process model. We'll delve into that. And then there's just some other little pieces that I didn't know how to categorize them. And so we're going to talk about so sleep hygiene, which is actually going to be a very small portion of this training. And I have to imagine it's possible that somebody thought, how are we going to talk for 3 hours about sleep hygiene? We're not. Sleep hygiene is a small portion. I'll talk about what it is, how it kind of fits into the context of treating sleep disorders. But for a lot of people, sleep hygiene is actually not, it's not that it's bad, it's just not going to be that helpful. And I'll also talk about sleep studies. When do you need a sleep study? When is a sleep study not going to give you any useful information? As well as naps and time management. And then the kind of the media, and then we'll take a break. My plan is to get through insomnia and then take a break and then come back and do the rest of it. So then I'm going to cover 5 different sleep disorders. There's other sleep disorders, but these are some of the most common ones, the ones I think people are most likely to see. And for each sleep disorder, I'm going to try to give you guys like a little something behavioral, like something you can do, something that you can try with your clients that are having trouble sleeping. So we're going to cover insomnia, nightmare, sleep apnea, hypersomnia, and then we're going to do kind of a deep dive into the circadian rhythm. So you're going to learn probably more than you ever thought you wanted to know about the circadian rhythm, but it's really important. Plays a big role in what people's sleep looks like. So, all right. So this is what we call the 2-process model, and there are 2 biological processes that have an impact on what your sleep looks like, and formally we call them process S and process C. But we almost never use those terms in talking to clients about them. Process S, mostly you'll hear me refer to this as the sleep drive. There's lots of other words for it: sleep homeostatic drive, sleep load, and it's all a bunch of different words to mean the same thing. But this is what determines how much sleep you get and how good that sleep is. So sometimes the issue, like particularly with insomnia, sometimes it's a sleep drive issue. It's an issue of they don't have enough sleep drive. And there's also things that people do that actually work against their sleep drive. So we'll get into that when we get into the insomnia section. But sleep drive is just, it's like this pressure that just builds throughout the day. The longer you go without sleeping, the more sleep drive is going to build up. So sleep drive, completely unrelated to what time it is. It's only related to how much is built up in the system. So if there's not enough sleep drive built up, you're going to have a really hard time falling asleep. You're going to have a really hard time staying asleep. I was told to kind of think of it like you're filling a balloon. And as the day goes on, it's like you're filling the balloon, filling the balloon, filling the balloon. And you really want that balloon to be like full and taut so that when you go to sleep, you let the balloon go and it deflates. And you want it to have enough air to carry you through the night. And so this diagram here just shows the sleep drive just building, building, building throughout the day. It's not uncommon for people with insomnia to go to bed too early, and sometimes the problem is they just haven't been awake long enough. So if you've ever, and I know I've done this, but I think we've all, where you sleep super late and then you turn around and try to go to bed early and you just have not been awake that long. It's hard to fall asleep in part because you just don't have enough sleep drive built up. And then once you fall asleep, the sleep drive burns off throughout the night. And then the whole thing starts over again the next morning. And then there's also your circadian rhythm, which we're going to delve a lot more into that a little bit later. But your circadian rhythm, it's a roughly 24-hour biological rhythm that one of the things it does is it determines the timing of when you're asleep and when you're awake. So if you ever heard people being described as like night owls or early birds, that's their circadian rhythm. Their circadian rhythm is skewed a little bit later or a little bit earlier. And so your circadian rhythm can get disrupted by big changes in your schedule. So, like jet lag, that's a circadian rhythm issue. We'll talk about when we get to that point. I'll talk just a little bit about jet lag. There is actually some guidance from the American Academy of Sleep Medicine for how to adjust if you're traveling eastward versus westward. It's kind of a pain in the ass. A lot of people decide they don't want to mess with it, but there is guidance for how to do that. But also, people can disrupt their circadian rhythm even if they're not traveling. Just the big thing is if somebody is getting out of bed at wildly different times throughout the week. And so I always tell people, try to keep it within an hour. The time you're getting out of bed throughout the week, try not to let it swing more than an hour. And we say an hour because that's daylight saving time. And we know that has it, like we know that impacts people's mood and alertness level and all that kind of stuff. And so if somebody is highly varying the time they're getting out of bed throughout the week, we actually call it social jet lag. It's jet lag. They're giving themselves jet lag. They're not traveling, they're not going anywhere, but they're giving themselves jet lag and thus disrupting their sleep. And so this down at the bottom is the circadian rhythm, specifically the circadian alerting signal. So you're going to be more or less alert at different times throughout the day. Most of us, when we first wake up, we're not that alert. Some people have this idea that if you slept well, you should wake up and just be bouncing out of bed, ready to go, full of energy. Nobody, nobody does. I mean, maybe some people, but very few people do that. It can take anywhere up to like 20 to 30 minutes before you start to feel kind of awake. And that's normal. So I like to tell people that it's actually kind of unrealistic to expect that you're just going to bounce out of bed and be ready to go. Like no, nobody does that. It takes a little bit of time to wake up and get going. And then your alertness level will rise throughout the morning. And then it's not really clearly depicted on here, but we all have a dip sometime in the afternoon. Usually it lasts like an hour or two. Typically it is 7 to 9 hours from the time that you wake up. So we all have that time in the afternoon where we just feel a little bit sluggish, a little bit low energy. We kind of dip and then we come out of it. And so that's another thing I like to tell people is that that's normal. Like people with insomnia, they're so anxious about their sleep that like if they don't wake up ready to go, they think they slept terribly. Or if they think they have to be full of energy all day long. And nobody is full of energy all day long. We all have a dip sometime in the afternoon. And then most of us get a little bit more alert as the evening wears on. So this example, this person's hitting peak alertness at 9 p.m. Some people are going to be later, like teenagers, for example. They're going to be much later. And so sometimes the problem might be that you're trying to go to bed if you don't have enough sleep drive built up. Sometimes the problem is that you're trying to go to bed and your circadian alerting signal is still too high. There's a period of time for most adults, it's like 6 to 8 or 7 to 9 p.m. And it's called your wake maintenance zone. And it's this period of time where it's pretty much impossible for you to fall asleep. Well, teenagers, their wake maintenance zone is later. And so at some point, you hit your peak alertness and then it starts to drop off. And now it's getting more likely that this person's going to be able to fall asleep. They're getting less and less alert. They're falling asleep, say somewhere in here. And then sometime overnight, of course, your circadian alerting signal is completely off because you're asleep. Sometime over the course of the night, your body hits what's called its temperature minimum. So this is when your body temperature is its lowest in a 24-hour period, and we tend to hit it about the same time every day. For most adults, it's 4 in the morning, and you will tend to wake up 2 to 3 hours after that temperature minimum. So for most teenagers, it's much later. So when we get into talking about the circadian rhythm, we'll talk about how like teenagers, their temperature minimum might be, I don't know, 7 in the morning or something like that, like much later. But these are the two biological processes that have an impact on what your sleep looks like. And then we're going to deep dive more into the circadian rhythm a little bit later. So I also want to talk about sleep architecture. This is just a fancy way of saying what sleep typically looks like over the course of the night. So we have 4 stages of sleep that we cycle through multiple times throughout the night. And they divide them, I'm not sure why they divide them this way, but they divide them first into REM and not REM. So N means not REM. And then not REM is divided into stage 1, stage 2, and stage 3. So N1, this is your lightest stage of sleep. This is kind of when you first fall asleep at the start of the night and you're kind of transitioning between wake and sleep. You're in N1. Very easy to wake up. There's some weird stuff that can happen here that's usually not a big cause for concern. People will have some people will hallucinate. They'll think they hear like a crash or someone calling their name. If that's happening like super regularly and it's causing the person a lot of distress, I would say refer them for a sleep study, because that's, you see that in narcolepsy a lot. But it's not uncommon to, like, here and there, just, you think you hear something, or you can have this thing where you like jerk awake all of a sudden. It's called a hypnic jerk, and they're weird and they're kind of disorienting. But again, they're usually not something to be concerned about. Just kind of wacky stuff happens when we're transitioning between wake and sleep. That's N1. It's like 2 to 5% of the night, tiny little portion of the night. Most of our night is spent in N2. This is a deeper stage of sleep. It's not the deepest stage of sleep. It's not the lightest, somewhere in the middle. This is 45 to 55. So about half of your night is going to be spent in N2. This is just a further slowing of everything. You're a little bit harder to wake up. Your heart rate slows down. Your blood pressure drops. There's like characteristic, like you can tell what stage of sleep someone's in by looking at an EEG. And there's two like very specific types of brain waves that you see into. N3, this is deep sleep. So when people talk about deep sleep, they're talking about N3. N3 is dead to the world, impossible to wake up. A lot of the time, people with insomnia are not getting very much N3. Can also see that in people with sleep apnea. We'll talk about sleep apnea in a little bit, that they're waking up so much, they're not staying asleep long enough to ever get into N3. But this is deep sleep. It's only 10 to 20% of your total night. And so a lot of people kind of think, oh, I should fall asleep and be in deep sleep the whole night and then wake up. No, you're not supposed to be in deep sleep the whole night. You move through light and deep sleep. It's normal to wake up during the middle of the night. There's some really specific things that can happen in N3. They're mostly seen in kids. Sleepwalking and sleep terrors are happening in N3. Sleepwalk. So like my brother sleepwalked when he was a kid. We could not wake him up. He's walking around. He seems like he's conscious. He's not. He's dead to the world asleep. He has no idea what's going on. He's not going to remember it the next day because he's actually in the deepest stage of sleep while he's up walking around. Sleep terrors, which typically you're going to see it for the most part, kids tend to grow out of these things. That's happening in N3. So the person that's screaming and yelling, they're dead asleep. They have no idea what's going on. They are not going to remember it the next day. They are very hard to wake up. That's N3. And then REM. REM stands for rapid eye movement. This is about a quarter, 20 to 25%, about a quarter of your night. This is where most of your dreaming happens. We dream in all stages, but the dreams that we have in REM are much more vivid. They're more of like a story or a narrative, so we're more inclined to remember them. Nightmares, those are happening in REM. So people tend to remember nightmares. Nightmares tend to wake you up because REM is actually a pretty light stage of sleep. So nightmares, that's mostly happening in REM. People they wake up, they very quickly realize they're awake and that they're no longer asleep. Usually people are able to kind of articulate, oh, I had this terrible dream and this happened and this happened. So nightmares are happening in REM. Night terrors are happening in N3. We'll talk about, there is some behavioral stuff you can do for nightmares. We'll be talking about that. There is behavioral stuff you can do for night terrors. I just didn't, I don't know, this presentation's already 3 hours long. So I had to cut, I couldn't have everything. But there are some things you can do for night terrors as well. We tend to get most of our deep sleep in the first half of the night and most of our REM sleep in the second half of the night. So like sleepwalking, sleep terrors, you're mostly going to see that in the first half. Nightmares, you're going to mostly see that in the second half. So, and this is more or less like typically how we cycle through. Lots of stuff can change this. Alcohol changes this dramatically. So alcohol, people tend to go right into N3 and then they rebound and they wake up. And then the rest of the night is like this crappy in and out, super light. So alcohol like very drastically changes this. But typically it's like, N1, then into N2, then we go to our first N3, then back to N2, then maybe we hit our first REM cycle, hour and a half into the night. And then you'll just notice as we go, the N3s are getting shorter, the REMs are getting longer. It's normal to wake up over the course of the night. People sometimes have this idea that they should not wake up at all. That's unrealistic. We tend to use 30 minutes as the cutoff for what's normal and what's maybe a problem. If someone's awake for more than 30 minutes or they're super distressed about it, then that's where we start thinking it's a problem. But little awakenings here and there, not necessarily cause for concern. Okay, and then let me just check our time. Okay. So I do want to talk about sleep hygiene and kind of what it is and what it's for and where it fits into all this. And so I think I posed this question earlier. So I'm gonna tell you what, before I became like a sleep person, that was what I did. I was like, oh, you can't sleep. Here's some sleep. Let's talk about sleep hygiene. And it's not that it's bad. It's just not always exactly what people need. It's not always sufficient. So what is it and where does it actually fit into all of this? What's its purpose? So there's a difference between hygiene and treatment. So sleep hygiene, the definition of sleep hygiene, it is making sure that your bedroom environment and your daily habits are as conducive to sleep as possible. So I was told to think of it. I put this picture over here of like some dental stuff. Think of it like brushing, flossing, going in for your 6 month dental checkup. It's preventive care. Um, and so it's good. Everyone should be doing it. Everyone should be brushing their teeth. Everyone should be practicing good sleep hygiene. But it's not intervention or treatment. So if somebody has insomnia or nightmares or some other kind of sleep disorder or circadian rhythm disorder, sleep hygiene's not going to fix it. And so it's kind of like you have a cavity. We need to fix the cavity, drill out the rotten part of the tooth, fill it, get that fixed up. And then, of course, the dentist is going to say, please continue to brush and floss to prevent future cavities, but it's not going to address if there is a cavity. So think about sleep hygiene kind of like brushing and flossing. And it is something that when I work with somebody with insomnia, once we get their insomnia corrected, I will say, let's put some sleep hygiene in place to try to keep this on track and try to keep the problem from coming back. It's very useful for that. It's just not going to correct the problem. There is also no definitive list of sleep hygiene. There's no one like, oh, this is the list. There's lots of lists that are out there circulating. Here's just some common things that show up on sleep hygiene list. And so it's stuff like exercising. I say 8 to 10 hours for caffeine. That might be a little conservative, but the half life of caffeine for most adults is 4 to 5 hours. So I just double it and say 8 to 10, just to be some lists will say 6. It really varies a lot. Like people's sensitivity to caffeine really varies a lot. So I say 8 to 10 just to be conservative. Of course, making sure your room sleep loves dark, cold, and quiet. Trying to not use like alcohol and nicotine, of course, will both really screw with your sleep. Um, I mean, but nicotine, the thing about it's a stimulant, but people will always say, "Oh, it calms me down." And sure, because it's stopping withdrawal. Like it's not that it's a depressant or a sedative; it's stopping withdrawal. And so I'll tell people for alcohol, I'll say try to keep it to like 2 out like a 2 hour window before bedtime with no alcohol and no nicotine, and don't use nicotine overnight. Like if you wake up in the middle of the night, try not to smoke. It's the guidance that I mean, really the guidance is stop drinking and stop smoking. But if that's not a realistic goal, then those are the parameters that I give people. We'll talk about naps. So some people naps are fine. Some people naps are even good, and other people naps are going to be counterproductive. So we'll talk about that. And then this is useful for some people, especially like older people that eat dinner early. There can be a long gap between dinner time and bedtime. And so if there's like a several hour gap between dinner time and bedtime, then it's a good idea to eat just a light little snack like crackers, bread, something like that before bedtime, because sometimes you can have a blood sugar drop during the night and that can affect your sleep. So this is just this is the equivalent of brushing and flossing for sleep. Okay. And then so let's talk about naps. So naps. So a question, you might ask the question, are naps good or are naps bad? And the answer is yes. The answer to that is yes. So the nuance around that is that naps are not, they're not bad full stop, but there's a good nap and there's a bad nap. So naps are going to use naps consume sleep drive for better or for worse. A nap will you're sleeping. So a nap is going to consume your sleep drive. So you kind of have to think about sleep drive as like a budget or an allowance and really consider, do I have it in the budget? So if you have insomnia, you probably don't have it in the budget. For your average person with insomnia, a nap is not going to help. It's not going to help them feel any better because there's a difference between being tired and being sleepy. And it's okay to take a nap if you're sleepy. So, sleepy is high likelihood that you're going to fall asleep. And that's kind of all it is. Like, if you're not falling asleep, you're not sleeping. If you're sleepy, you are almost assuredly going to fall asleep. Sleepy is eyelids are heavy, head is bobbing forward, you're having lapses in concentration, you're having to read the same thing over and over, and you're like, wait, what did I just read? Like, you are literally falling asleep. That's sleepy. Tired is different. Tired is like fatigued, dragon ass, low energy, cranky, irritable, which is different from sleepy. You can be tired without being sleepy. And most people with insomnia are not sleepy. They're tired but wired is the phrasing that we use. So a nap, if you're fatigued, if you're like fatigued, low energy, a nap is probably not going to help you feel any better. What's probably actually going to help you feel better is to get up and move around. Because a lot of the time, fatigue is counterintuitive. People think, oh no, I need to be resting because I'm tired. But fatigue, sometimes to get out of fatigue, it helps to to get up and stretch and move around and get active. But it's okay to take a nap if you are, again, if you're sleepy, like you're literally falling asleep and you might need to burn off some of that sleep drive. So, like people who do shift work will sometimes take a short nap before their shift. Um, you can use naps. People with like narcolepsy, scheduled naps are actually part of the treatment. So, depending on what's going on, a nap could be recommended or useful, or it could be totally counterproductive. But you want a nap for sleepiness, but not for sleep. So don't use a nap to be like, well, I only slept 6 hours last night. I need 8 hours of sleep, which, by the way, not everybody's an 8 hour sleeper. People get super rigid about that. Like, I must have 8 hours or it's all shot to hell. And we all have a sleep need. We don't all have an 8 hour sleep need. Somebody might be a 7.5 hour sleeper. And if you oversleep your need, you end up having to pay it back. And so too much sleep can be just as problematic as too little sleep. So you don't want to take a nap to like make up for last night. Like, we can't go back. If last night was rough, that was just what it was. We can't go back in time and make it better. We just keep moving forward. So take nap for sleepiness, but not for sleep. And here's kind of the criteria for a good nap. It's short. Um, like 15 to 20 minutes. I always tell people set an alarm for 30 so that you don't go past that. Try to time it in that circadian dip. So it's possible. I mean, we don't know what the function of that circadian dip is, but some people make the argument that humans were meant to nap, and that's why we have that energy dip. Is that true? I have no idea. But 7 to 9 hours, 7 to 9 hours after the time you wake up, if we're going to get real technical, it's 7 to 9 hours after your habitual wake time. So that's the time you typically wake up. So that may not be the time that you woke up that particular morning, but whatever time you typically tend to wake up, 7 to 9 hours after that, try to time it in that dip. And in your bed. You're sleeping. So be in your bed. All right, so now kind of shifting into, I want to talk about, let me just check my, okay. Um, so sometimes it's not really a sleep issue, it's more of a time management issue. And so I think like if you hear people say things like, I just can't get to bed at a decent time, um, to me, that isn't so much about their ability to sleep. It's more about how the time is managed throughout the day. Because your typical person with insomnia, they're going to bed way too early. They're going to bed way too early. They're not going to say, I can't get to bed. They're like, I must go to bed at 9 and spend 12 hours in bed. And they're typically not going to say, oh, I just can't get to bed at a decent time. I see this a lot with like ADHD, executive dysfunction. And so why, some reasons why it might be difficult. So you kind of want to discern, like, does this person really not have the ability to sleep? Or do they maybe need more help? Do we need to figure out how to manage the time during the day so that they're not staying up too late? Because these people are pushing past, like, there's a point where they're sleepy and their body is telling them, go to sleep. And they're pushing past it versus people with insomnia, they're going to bed before they feel sleepy. So a lot of it's like time blindness. My experience with like ADHD executive dysfunction is that distal goals are not that motivating. So like what I'm doing now is more important than how I'm going to feel tomorrow. Like that's tomorrow Jessica's problem, and I'm not worried about that. And so both between the time blindness and kind of that lack of drive for how I'm going to feel tomorrow makes it hard to stop what you're doing. So these are people that often have to set an alarm to remind themselves to go to bed. Sometimes what's going on is that, and this is that revenge bedtime procrastination, if you guys have heard about that. Um, Sometimes it's that you finally have time where you're not at work and the kids are in bed and the spouse is in bed and nothing is pulling on you. Finally, nothing is pulling on you. You finally have alone time. And so then they're like, well, this is the only time I have. I have to stay up late because this is the only time that I have. Or just if your bedtime and your wake time are super erratic, like that's kind of no matter what the sleep issue is, or even if you don't have a sleep issue, that's really good for everybody is to try to go to bed and get up, especially the wake time. Um, try to make that consistent. And when we get into talking about the circadian rhythm, we'll kind of talk about like why that is so important. But maybe that's the issue. Maybe that the problem is that they're basically jet lagging themselves, that their bedtime and their wake time are so erratic that their brain does not know what time it is. Their brain is like, is it day? Is it night? I have no idea. Should we be awake? Should we be asleep? I don't know. I'm just going to throw out a guess. And then, you're wired at 2 in the morning or you're falling asleep at 4 in the afternoon, because we have to kind of let our brain know what time it is. And one of the ways we do that is like doing things at the same time every day. So I've just got some pointers here for people who it's really like a time management issue. So for these people, it's going to be really important to have a clear set bedtime and they stick to that bedtime. For people with insomnia, just to distinguish this, they tend to get so rigid about I have to go to bed at 9, I have to go to bed at 10, it has to be this time. So for insomnia, we're trying to find more flexibility and we're trying to find like hey, go to bed like when you feel sleepy. That might be 9, it might be 10, it might be 11, but don't get into bed until you really feel ready to fall asleep. But for these people, the people that are like pushing past their sleepiness, having a just having a rigid bedtime for these people is actually helpful. Um, Also, to try to start like about an hour before bedtime. Try to stop whatever you're doing, start transitioning, start easing off the day, or yeah, easing off the day, easing onto the night. We're trying to like cue our brain, like, hey, brain, we're moving toward bedtime. Let's start kind of calming everything down. Also, if you can try to figure out a way to manage the time differently so that maybe can we try to get more downtime or me time earlier in the day? Can we just try to shift and this may take some creativity and some problem solving, but can we try to shift that to a different time of the day so that you're not staying up too late? And then finally, sometimes it's just reminding yourself of the consequences. Because when you're sitting there, whatever you're doing at night, it's fun, it feels good. You're not thinking about how crappy you're going to feel the next day. And so making a list of like, okay, what are all like, I'm going to feel crappy the next day. What are all the consequences? What are all the reasons I want to do this? And trying to have that list handy. So when they're like, I don't want to go to bed, they can remind themselves of, oh, yeah, here's all the reasons. Here's all the reasons I do want to go to bed. So sometimes it's a time management issue. Sometimes those are the levers that you pull. Okay. Um, so I want to talk now about sleep studies and what they are, what they measure, when to recommend one, when to not recommend one. So there's really two different ways of objectively measuring sleep, and they are polysomnography and actigraphy. And to kind of to define what these are, I just broke down, I looked up the etymology of these different pieces of the word and just kind of broke down what each part of the word means. So polysomnography means many ways of measuring sleep. And so when you send somebody to a sleep lab, probably what they're going to have done is polysomnography. And there's different level. I think there's like 4 different levels of polysomnography. The most basic level measures like 2 things on up to, I think the highest one I think measures like 7 or 8 things. But here's some examples. This is the kind of data that you're going to get from polysomnography. And so I'll talk about this and I'll talk about what disorders this. So polysomnography, again, depending on what level of polysomnography, will hook somebody up to an EEG, which will tell you what's going on with their brainwave. That's how you know what stage of sleep somebody's in. Like that's really the only way that you know what stage of like the smartwatches they guess, but really the only way to truly know is to get an EEG because there's characteristic like brain waves for each stage of sleep. So I think that's electroencephalogram. This is electrooculogram. So this measures your eye movement. So they'll use this to know if somebody's in REM sleep, just if their eyes are moving back and forth the way they do in REM sleep. Um, Muscle movements is another thing. So if somebody's like kicking and jerking or punching during the night, this is going to be really helpful for, okay, what stage of sleep are they in? Are they in REM? Are they moving? And then stuff like airflow and oxygen saturation. So this is how you diagnose sleep apnea. So sleep apnea, if you suspect sleep apnea, refer somebody for a sleep study. That'll tell you, do they stop breathing? So it can tell you if somebody stops breathing during the night or if their oxygen saturation drops. It'll tell you if somebody is there's a disorder called periodic limb movement disorder. It's kind of like restless legs, but it's happening while you're sleeping. um, this will tell you, are they moving around during the night? Are they in REM sleep? What are their brain waves doing? And so there's some sleep disorders that this is really useful information and it'll tell you why someone's not sleeping. And there's other sleep disorders, and we'll break it down on the next slide, that the reason that like insomnia, the reason they're not sleeping has nothing to do with any of this. It's not their airflow. It's not their. It's not any of this. So if you just suspect insomnia and someone goes to get a sleep study, they're probably not going to get any useful information. And we'll break down like what are the criteria for insomnia, what do you look for with sleep apnea, but that's polysomnography. There's also actigraphy, which is just measuring movement. And there's two different types. There's medical grade and consumer grade. So consumer grade, that's all the like the smartwatches. That's all like the Apple Watches and the Garmin's and the rings and all the things that people have to measure their sleep. Really, what it's doing is it's measuring movement. And it's essentially saying if you're not moving, then you're sleeping. If you are moving, then you're awake. So it's not the most, we don't know how accurate any of these, like, Apple Watch it. We don't know how accurate any of those things are because the companies haven't made their algorithms public, which, it's their product. Why would they want to do that? But because of that, like the people who study sleep, we don't really know how they're working. So we have no idea. Um, Also, people with insomnia, these consumer grade wear, like they make them more anxious. They will be like, oh my God, my watch says I slept terrible. And my watch says I only had this many minutes of REM and this many minutes of deep sleep. And I actually hate, I actually hate consumer grade wearables for people with insomnia. They are the bane of my existence. Because also people will wake up in the morning and they'll feel okay and they'll feel like they slept okay. And then their watch tells them they slept like crap. And they're like, uh-oh, I can't even trust my own judgment of how I'm sleeping. And then there is medical grade actigraphy. You might see like a lot of like sleep labs and sleep doctors. Sometimes they'll give the patient like a thing to wear, or like I don't really use a lot of that as just a private therapy practice, but you might get like if somebody works with a sleep doctor, depending on what's going on. Yeah, there's also medical grades. There's two different types of actigraphy. Okay, so I want to break down, and we're not going to talk about REM behavior disorder, but I'll define what that is. But we are going to talk about sleep apnea, narcolepsy, insomnia, circadian rhythm, nightmare disorder. So when is a sleep study a good idea? Well, if you suspect sleep apnea, and we'll talk about like what to look for, what that looks like, but that is because a sleep study will tell you, do they stop breathing in their sleep? How often do they stop breathing during their sleep? They'll also tell you if there's any like if there's any respiratory effort, like if they're struggling to breathe. So sleep apnea, 100% need a sleep study to diagnose that. Also narcolepsy. We'll talk about kind of how this might show up. But that's also something that you need a sleep study, and it's pretty involved. The narcolepsy sleep study. REM behavior disorder, this is something you're going to see this if you work with particularly elderly men. That's who tends to develop. But this is just a thing where they act out their dreams. They're punching and kicking while they're in REM sleep. And that shouldn't be happening. Your body is supposed to be paralyzed when you're in REM sleep to keep you from acting out your dreams. So if you have anybody that is doing this, or they say their spouse is, a lot of times they'll tell me the spouse is doing it. It's probably gonna be an elderly man, but refer them for a sleep study because that's gonna help determine. And there is a treatment for that. It's basically melatonin, which is really interesting. But so just yeah, if you have someone who's punching and kicking, acting out their dreams, refer them for a sleep study. But if we're looking at insomnia, like insomnia is behavioral. If somebody has insomnia, the reason they're not sleeping, it's behavioral. It's stuff they're doing that's getting in the way. And a sleep study can't measure someone's behavior. It can't tell you, it can't measure that they're exerting too much effort. It can't measure that they're getting out of bed at different times throughout the week. A sleep study can't measure that. Circadian rhythm disorder. So these things can look a lot like insomnia. And so we'll talk about kind of how to distinguish the two. But also sleep study is not going to measure, because the way that you measure someone's circadian rhythm is you have to measure like their temperature minimum and like they're not having a circadian rhythm disorder because of all the stuff we looked at that the sleep study measures. And then finally, nightmares. It's not going to tell you why someone's having, most likely. Now, there is sometimes people with sleep apnea, with untreated sleep apnea, they have nightmares. And when you treat the sleep apnea, then the nightmares can get better. But if it's nightmare disorder, which we'll define that, sleep study is not really, because this is all behavioral. This is all like behavior changes. The reason people are struggling, a lot of it's behavioral. So this is when you want to refer for a sleep study. This is when a sleep study is probably not going to give you much useful information. All right, so let's get into, I wanted to kind of talk through insomnia. And then we'll take our break and then we'll come back and kind of talk through the rest of the disorders. But I want to talk through a few different sleep disorders, kind of define the criteria and kind of what they look like, and then also try to offer you guys like explain what the treatment is, and then try to offer you guys like some little nugget from each of these behavioral treatments that you could take and apply. So insomnia. So what is insomnia? It's really about difficulty either falling asleep or staying asleep. We tend to use 30 minutes as the cutoff. 30 minutes is not in the DSM, but that's what we tend to use in the sleep world. So meaning it's taking you more than 30 minutes to fall asleep, and or you're spending more than 30 minutes awake over the course of the night. It might be 30 minutes in one big chunk, or it might be like they wake up a lot, but it adds up to at least 30 minutes. So, really, as far as how long it should take you to fall asleep, 10 minutes to 30 minutes is what's considered normal. If somebody's fallen asleep in like 5 minutes or less, that's not always a good sign. That might mean they have untreated sleep apnea. So that's another thing. If their head hits the pillow and boom, they're asleep and they're snoring up a storm, that might be sleep apnea. People with sleep apnea, people with narcolepsy, drunk people, humans are really not supposed to like slam into sleep that quickly. So 10 to 30 minutes. If it's taking more than 30 minutes, or they're awake for more than 30 minutes over the course of the night, or they wake by more than 30 minutes too early and can't get back to sleep. It doesn't have to be all of those. It could be, or it could just be one or two. Also, to call it insomnia, it has to be at least 3 nights a week for at least 3 months. Everybody has bad nights. Everybody has, we all have little blips of acute insomnia. You're going through a stressor, a life transition, your sleep gets disrupted. And so, again, I'll have people that like they had 2 bad nights and they're panicked and they're like, I have insomnia. And they technically don't. um, because to diagnose insomnia, it's at least 3 nights a week for at least 3 months. And then the other, of course, and this is like in every DSM thing, we're looking for, it's really a 24-hour disorder. So we're looking for it to impact their functioning. This is subjective. Um, Usually people with insomnia are functioning better than they think they are. But people will say, I can't concentrate very well. I'm grumpy with my kids. I just don't feel good during the day. There's just some sense that they're not performing up to what they're capable of, or they're super distressed about it. Like if somebody's sleeping 4 hours a night and they're like, this is fine, I'm happy with this, this works for me, that's not insomnia. Insomnia is, I'm not sleeping and it is wrecking my life. And then, of course, the other criteria that I didn't put on here is like differentiating between insomnia and a circadian rhythm disorder. So we'll get into those in a little bit. So this is called the behavioral model of insomnia. And so this is kind of looking at, there's these 3 sets of factors, and whatever caused it and whatever's keeping it in place are not usually not the same thing. And so this is the passage of time along the bottom. And then this is just how, how severe the insomnia is going along the edge here. So typically people who go on to develop a pattern of insomnia, and we really think of insomnia as like it's a learned behavior that's become a habit. So people who are predisposed are all this stuff over here. So people who are just already anxious in general about other just anxious people um, tend to also be predisposed to develop insomnia should the right set of stressors come along. People who are health conscious, you're going to see a lot of this in your insomnia clients. People, this is all the people that are they're tracking all their metrics and they're obsessed with the data. And so people who are already, or people who are really preoccupied with like how they're functioning during the day, like the kind of people who want to like optimize their functioning, those kind of people, they're really prone to developing insomnia. Those are really the top two. Also, people with a family history, it's not genetic, but I think there's just some learned behaviors and attitudes that come through families that are going to predispose people to insomnia. And then, of course, a trauma history. A trauma history seems to predispose you to almost any kind of health issue under the sun. So this is no different. So these are your predisposing. This is just the stuff about you that didn't cause it, but pushed you a little closer to the threshold. And then a lot of the time, there is something. Some people have never been good sleepers, but a lot of the time, there is something that happens that causes it. It's usually some life stressor or transition. It might even be a good one. So, like some of the big ones are graduating college, having a baby, and retiring. Those are three, like, if people were going to develop insomnia, those are three phases of life where it seems to happen a lot. And I mean, any of these things are going to disrupt your sleep short term. You're transitioning to a new schedule, you're worried about finding a job, your baby's not sleeping through the night. With retirement, people's schedule really changes. A lot of the time, they lose all structure, and the time they're getting out of bed starts to really vary, or they're less active during the day. But for a lot of people, they adjust, and you'll notice that this line goes down. There are people who just go back to normal sleep. They have a few weeks of rough sleep, or maybe even a month or so, because we really don't diagnose insomnia until it's 3 months. So these people, okay, little blip on the radar. They go back to normal, nothing to worry about. And then there's the people who the sleep problem starts to take on a life of its own. So now maybe they found a job and they're settled into their new job and they're still not sleeping, or the baby's sleeping through the night, but they're still not sleeping, or they've adjusted, they figured it out, the stressors pass, but they're still not sleeping. So this is where we get into what are called the perpetuating factors. So whatever caused it, we've left that behind. We're 3 months down the road, you're still not sleeping, and now there's no cause that you can point to. It's become its own problem. So there's this idea that insomnia is always secondary to something else. So people will think, oh, if we could just treat the depression or treat the anxiety or treat whatever it is, the insomnia will go away. Sometimes, but not always, especially if it's at least 3 nights a week for at least 3 months, we're in chronic insomnia territory. And so what usually happens is somewhere along the line, because these are people who were already anxious, they were already health conscious, and at some point they notice, oh shit, I'm not sleeping. Uh-oh. Uh-oh. This is a problem. This is a problem. I gotta fix it. I gotta fix it. And they start doing stuff, trying to fix it, that's actually making it worse or keeping the insomnia in place. So these are just some of the big ones. There's like three different areas if we're looking at what keeps chronic insomnia in place. It could be an issue with the sleep drive or the sleep homeostat. Something has gotten disrupted in the sleep homeostat. So, or the sleep drive. The biggest thing that really seems to cause that is too much time in bed. People with it, they will start spending more and more and more and more time in bed because they're like, I'm going to cast a big wide net, Surely it's kind of like buying really big, I don't know why anybody would do this, but buying really big shoes to try to make your feet grow. Like, again, I don't know why anybody would do that, but your feet aren't going to grow just because that extra space is there, and you're not going to fall asleep just because you're in bed, especially if you have insomnia, because you're probably stressed out and anxious, and so they start spending way too much time in bed. Or maybe there's a disruption to their circadian rhythm, which what really messes that up is erratic wake times. So trying to, because again, what's happening is people will linger in bed, they'll stay in bed, they're trying to get more sleep. So people will spend more time in bed trying to get more sleep. Or if they had a bad night, they'll stay in bed later trying to get more sleep. So now their wake time has gotten super erratic, or they sleep in on weekends because that's when they catch up. And all the while, again, they might as well be flying from New York to California every day. And you never, it's like, imagine if you were doing that, how messed up your sleep would get, because you're never like settled in any one place long enough to adjust to that. And so sometimes the sleep drive is messed up. Sometimes the circadian rhythm's messed up. Sometimes they're both messed up. And then there's this I call this the third thing that can just come in and screw it up, which is like arousal or anxiety or hyperarousal is sometimes what it's called. So this can override your sleep drive. So we have this, built-in alarm system that can override our sleep drive if we need to. Like, let's say our house catches fire in the middle of the night and you're dead asleep and your smoke alarm's going off. Well, this arousal system's going to kick in, wake you up, override that sleep drive so you can get out and get to safety, which is great if there's a true emergency. But what's happening in people with insomnia is they're getting into this cycle of sleep effort or just trying really hard to sleep. And they dig in more. Um, they're trying so hard and sleep doesn't reward effort. Sleep does not reward effort. The harder you're working at it, the worse it's going to get. I was told to think of sleep like a cat. Like, I don't know if you guys have cats, ever had a cat, ever knew anybody, but cats are very like, cats will come to you on their own terms. So a lot of the time, if you really try to pursue the cat and you like, come cat, I want to cuddle and give you attention, the cat's like, get away from me, don't touch me, I don't want nothing to do with you. But if you just kind of do your thing, just the cat's here, cool. You're kind of ignoring the cat. You're doing whatever else. A lot of the time, then that's when a cat will be like, "Oh, now I'm interested in you. Now I want to cuddle with you." Sleep is like that. The harder you pursue it, like this is a bigger thing, I think, than like the screens and the caffeine, and it's sleep effort. Because as soon as you start exerting effort, we're done. We're not falling asleep. If you're going to fall asleep, we got to take energy out of the system. We got to disengage. We got to, like, as soon as you start exerting effort, your brain is like, oh, my human's trying to solve a problem. It would be stupid of me to fall asleep right now because we need to solve this problem. But the problem is the problem that you're trying to solve is your sleep. So this is anything can be sleep effort, breathing, meditation, taking a bath, like anything people do, if they're doing it with all this pressure to try to induce sleep, it's likely to backfire on them. Like, I had somebody one time who was like, I meditated for an hour and a half last night and I still didn't fall asleep. And I was like, you did sleep effort for an hour and a half. That's what you did. You didn't meditate. That was sleep effort. Because I was like, I guarantee she was sitting there and been like, go to sleep, go to sleep, go to sleep. Breathe, breathe. Go to sleep, go to sleep. Why am I not asleep? Why am I not asleep? It's 11 o'clock, it's 12 o'clock, it's 1 o'clock. I was like, of course you're gonna fall asleep. You did sleep effort for an hour and a half. Um, okay, I think I have a couple more slides. All right, cool. So we have like 10 minutes till I want to take a break. And I think there's like 2 more slides. So the gold standard treatment for insomnia is cognitive behavioral therapy for insomnia. It is something that I offer. So I'm going to give you guys like one piece of CBTI that you can apply. But also, I do a lot of this like short-term adjunctive type of work. So I have people who will refer somebody to me just for CBT for insomnia. And they stay with they've got a long-term therapist that they're seeing for kind of everything else. They come to me, we just correct the sleep, and then I send them back to their therapist. So that's also an option. But it's typically six to 8 sessions. It's not a super long-term commitment. And really what it is we're directly intervening on those perpetuating factors. So we're figuring out what is it that's keeping this problem in place, and particularly what is the person doing that's keeping the insomnia in place. And these are sort of the components. So psychoeducation, it's basically the psychoeducation that I gave about the sleep drive and the circadian rhythm and the sleep architecture, and then that behavioral model of insomnia. That's all the same psychoed that I give to my insomnia clients. There's something called stimulus control, which has some evidence as a standalone therapy. So I'm going to talk you guys through that because that's something that can just be done on its own. There's also something called sleep restriction therapy. It's also really effective. Everybody panics when you say sleep restriction because they're like, I'm already not sleeping. What do you mean you're going to restrict my sleep? They named it badly because really what we're doing is we're restricting time in bed. We're not restricting sleep. I'm looking at how much are you sleeping? And I'm taking your time in bed and I'm just condensing it. Like, let's say you're averaging 6 hours of sleep a night. I limit you to 6.5 hours in bed. And that's another thing you can try, like cut time in bed by an hour. That should boost the sleep drive. The way you boost sleep drive is to be up and out of bed and moving around. You don't build sleep drive laying in bed. We do talk about sleep hygiene. There's a lot of cognitive work, so a lot of work that's done around just people's anxiety about their sleep. So people, it's always the insomnia people that are like, I'm going to die. They read the articles that are like, if you don't get enough sleep, you're going to get dementia and you're going to have a heart attack and you're going to die. And they're like, I'm going to get dementia. And I always tell people that it's like the people that they're writing those articles for the general public, not just for people with insomnia, but for the general public. A lot of the general public doesn't value sleep. People with insomnia value it probably too much, but a lot of the general public doesn't value sleep. And I said that I always say they're trying to reach those people that are like, I don't need to sleep. I'll sleep when I'm dead. Sleep is overrated. Like those people, which are not the insomnia people. That's a whole different group of people, but it's the people with insomnia that are reading because they're anxious and they're researching and they're trying to find answers. And so trying to kind of like to do some work around like this is not going to kill you tomorrow. Like you can survive. You can survive a bad night. This is not the emergency that your brain is making it. And then of course relapse prevention. So how to keep it on track, what to do if the problem comes back. That's CBTI. So I'm going to talk to you guys. Okay, cool. So I'll kind of go through this, and then that should take us to 10 after 10, and that's when I wanted to take our break. So here's something that you can offer to your clients with insomnia. This is called stimulus control. And the reason we call it that, so it's a behavioral treatment. And so the stimulus in this situation is it's the bed or maybe the bedroom or maybe bedtime, but something that's the stimulus. And we are trying to control the response to the stimulus. So we're trying to set up a situation where somebody goes to bed and they sleep, and that's it. And they go to bed and they sleep, and there's no variation. Insomnia can really be thought of as stimulus discontrol, which means there's a lowered probability that if they get into bed, they're actually going to sleep. Sometimes, there's a cycle. You'll see where they'll have good nights and then bad nights and then good nights and bad. They'll kind of like circle around. So what we want is stimulus control. This is it's very Pavlovian. A lot of people with insomnia will have this thing happen where they actually feel sleepy and then they get into bed and it's like a switch flips and all of a sudden they're wide awake and they're like, what the hell? I was sleepy 10 minutes ago. I was falling asleep on the couch. They climb into bed. They're not sleepy anymore. And that's a conditioned response. It's like you get into bed and your brain's like, oh, my human's getting into bed. It's time to worry. It's time to be awake. It's time to worry. It's time to be stressed. It's time to do anything and everything that's not sleeping. There's also just a lot of performance anxiety. Like they don't have performance anxiety around sleeping on the couch. They have performance anxiety around sleeping in their bed. So as soon as they get in, like the stakes aren't that high. If they sleep on the couch, whatever, but they're like, I must sleep in my bed. If I don't, and they'll say, like, if I don't sleep, I'm going to die. I'm going to crash my car tomorrow. I'm going to lose my job. It's all this super catastrophic thinking. So then, of course, that leads into all this sleep effort. Because if you're going to, oh my God, if you're going to die, like, my God, like, we can't give up the fight here. Like, we got to keep pushing. Like, we got to lower the stakes. Okay, so that's stimulus control. Here are the 5 components to it. The first component is to not get into bed until you feel sleepy. So go to bed based on how sleepy you feel, not the time. And most people go to bed based on the time. No, maybe not. I don't know if it's most people, but most people with insomnia, they go to bed based on the time. And so they think, okay, this is how long I think I need to sleep. This is what time I need to get up in the morning. I'm going to go to bed at this time because that's count back 8 hours. So it makes sense. It's not illogical. The problem is that a lot of the time people are going to bed too early. They're going to bed before they have enough sleep drive built up, or they might be going to bed when their circadian alerting signal is still too high, and then they're not falling asleep. And then they're stressed out and pissed off that they're not falling asleep. And as soon as we're stressed out and pissed off, we've lost the plot. We're not falling asleep. Very often people find if they go to bed later, they actually sleep better. Maybe they're not sleeping as much, but the sleep they're getting is much more quality. They fall asleep faster, they sleep through the night. There really is something about consolidating that time in bed that really like makes the sleep much more efficient. This takes some doing. Also, the other thing I want to point out is that this is going to take a week or two before people really see the full benefit. It's not going to fix it tonight. It's not going to fix it tomorrow night. So tell people, I'm like, give it 2 weeks before you decide it sucks and it doesn't work, because it's not going to fix it tonight. We're changing a habit. We're deconditioning a habit. That takes a little bit of time. So don't get into bed until you think you feel like, okay, I think I could fall asleep. Base it more on that than the time. This rule about getting out of bed if you can't sleep, people have probably heard this. It kind of floats around out there. So what I tell people is give it ballpark 15 to 30 minutes. I think you can give it at least 15. Don't go past 30, somewhere in there. If you hit 30 minutes and you still haven't fallen asleep, then get out of bed. Or as soon as you realize you're stressed out and pissed off. Because we're trying to decondition this response of getting into bed and becoming stressed out and pissed off. We're trying to turn that response off. So 15 to 30 minutes, or as soon as you realize you're frustrated. And really what this is about is giving up the effort. It's about 2 things. It's about we're trying to pair bed with sleep. So if you're not sleeping, you're not in bed. But it's also giving up the effort. Nobody wants to do this because they will always say, no, it's just around the corner. Sleep is just around the corner. I'm gonna any minute now. It's the next 5 minutes. It's just around the corner. And it almost never is. And so nobody wants to do this because they think, oh, I'm gonna stay in bed. I'm not gonna give up this fight. I'm gonna dig in. I'm gonna try harder. That's actually the worst thing in the world to do, because sleep does not reward effort. So get out of bed, go somewhere else. We're gonna give up the effort. Like, look, it's not working right now. We might be sacrificing tonight. We're going to give up this effort. Go somewhere else in your house if you can. If you can't, go somewhere else in the same room. If you can go from the bed to the chair. If that's not possible, last ditch effort, you can sit up in bed. But just stop trying. Stop pursuing it. It's not working. And as far as what you do, I give different guidance. We've started to give different guidance. The advice used to be do something boring. We don't say that anymore, for a couple of reasons. One is because that's sleep effort. People are like, oh my God, it has to be boring. It can't be too stimulating. And what's the right thing? And they end up just sitting there staring at the wall because they're so worried that they're going to wake themselves up. And I tell people, I'm like, no, my goal is for you to become a person who doesn't give a crap if you sleep or not. So do whatever you want, do something fun, play a game, get on the computer, watch TV, watch a movie, do whatever you want, because we don't care. We don't care if you get sleep tonight. And then don't go back to bed until you feel sleepy, keeping in mind the difference between sleepy and tired. So this is, again, it's not going to fix it tonight. It's probably not going to fix it tomorrow night. It's going to take a couple of weeks. Um, but that's what we're doing. We're giving up the effort. Get out of bed at the same time every day and get out of bed within an hour, regardless of how you slept. Even if you slept like absolute crap, you still get out of bed at your regular time. Because people think, oh, I can go back in time and make it. Like people think, oh, if I just stay in bed, I can make it better. I can somehow like I can make it better. And it never works. And then a couple of things are going on. If the time you're getting out of bed is varying a lot, you're disrupting your circadian rhythm. Also, the sleep you're getting, it might not be the best quality sleep. So we're trying to pair bed with good sleep. So if you're not sleeping or if you're sleeping crappy, then I kind of don't want you in bed. So when people are laying in bed trying to get more sleep, usually the sleep they're getting is not very good quality. So we're disrupting this effort to pair bed with good sleep. Try to use the bed only for sleep and sex is the one exception. So try to get everything else. If you can try to get it out of the bedroom, that's ideal. Um, but also, I work with people who live in like studio apartments and that might not always be feasible. And so then for them, I'm like, okay, let's just like the bed, just the bed. The rest of the room is the rest of the room, but we'll just keep the bed. So anything else, move to the couch, move to a chair, move to somewhere else. And then for people with insomnia, trying not to take naps, um, because naps are going to consume their sleep drive. And your average person with insomnia doesn't have a lot of sleep drive, which is why they're not sleeping to begin with. So this is stimulus control. This is something that has some evidence as just a standalone treatment for insomnia. So with that, let's take our 15-minute break. So let's come back. It's 10:12. And so 10:12 plus 15 is 10:27. Let's say 10:27. If we want to get that precise. Yeah, come back at 10:27. And I'll let me get back started here in just a second. Okay, go ahead and get my stuff. Make that 2%. Okay. And yeah, I was reading through the questions in the chat. I allotted myself some time at the end to answer questions. So I was just kind of reading through and um yeah, so I'll when we get to the end, I'll just kind of go through those line by line. Okay, so let's get back into this. So I want to talk now about nightmares. And so I think I made the distinction between nightmares and night terrors. So nightmares are a what's called a parasomnia. Para means alongside. And so parasomnias are any kind of disordered thing that happens alongside sleep. So like sleepwalking, sleep terrors, nightmares, those are all parasomnias. We divide parasomnias into REM and not REM. So nightmares are a parasomnia that happens during REM. Typically, you're going to see more of them in the second half of the night. And the definition of a nightmare, it's a distressing dream that wakes you up. So we actually make the distinction. I'm not sure why we make this distinction, but nightmares wake you up. Bad dreams, you don't wake up, you remember them the next morning. Because there is actually a treatment, CBT for nightmares is a thing that exists. It's also something that I do. And I'm going to share with you guys a little intervention from that. But it's a distressing dream that wakes you up. People pretty quickly become alert, realize it was just a dream. I mean, they're still activated for a while. It takes a while to come down, but very quickly they realize, okay, I'm awake. That was just a dream. It's not real. And then there's a lot of people that have I mean, people have nightmares on occasion. It's not always, sometimes people just get nightmares when they're stressed. Sometimes if people are having a lot of nightmares, that can actually be an indication that with sleep apnea, because with sleep apnea, people will wake up gasping for breath. And so people will be like, oh my God, I must have just had a nightmare. I don't remember it, but I must have just had a nightmare because I'm gasping for breath. But the other piece of it, of course, is that you're looking for, if we're going to call it a disorder, that the nightmares are super distressing. They're putting off going to bed because they don't want to have a nightmare, or they're smoking weed so they can suppress their REM and not get nightmares. Or there's some kind of impairment, they're not getting enough sleep, and so they feel impaired during the day. So this is kind of like what we might call nightmare disorder. I would say if somebody's averaging if it averages out to at least one nightmare per week, then I think it's worth getting it treated. That's kind of the cutoff that we use for when do you offer nightmare treatment. And then I'll also share CBT for nightmares, because a lot of people who have nightmares have PTSD, and so you might think, well, we just treat the PTSD. And a lot of the time that takes care of it. You treat the PTSD, that knocks out the nightmares. Sometimes people will get their PTSD treated and then the nightmares still stick around. So those would be people that CBT for nightmares they might be a good candidate. Or sometimes there's people that have PTSD, but they're just not ready to like plunge into a trauma treatment, but they would like some symptom relief. So you can at least get in there and tackle the nightmares and relieve that part of it. So those are kind of the two groups of people that CBT for nightmares is good for. So just a couple of theories about why do we get nightmares. So nightmares are really thought to be, generally speaking, they're a learned behavior that's become a habit. You do want to make sure if someone's getting nightmares, check the medications that they're on. Some medications have nightmares as a side effect, and so always just check and make sure it's not that. Sometimes people get nightmares, they have untreated sleep apnea, and if you treat the sleep apnea, the nightmares go away. But here's kind of the two, but other than like those types of situations, we really think of nightmares as like this, it's like this path that your brain always takes. It's this, again, it's a learned behavior that's become a habit, just like insomnia. And it's like your brain always takes this particular path. There's two different theories. One is the trauma processing theory. So it could be that the purpose of the nightmare is your brain is just trying to understand, try to make sense of what happened, trying to work it out, trying to figure out what to do. That's one possible explanation. And then the other possible explanation is more about whatever our mood was when we were falling asleep. It's kind of like when when you're pissed off, you want to listen to pissed off music. And when you're happy, you want to listen to happy music. When you're sad, you want to listen to sad music. So this might be another possible explanation for why people get nightmares. But we think it's just kind of like it gets stuck. And then it's just like a record that skips. And you can interrupt that process. But here's so CBT for nightmares blends two different treatments. So one of the things it pulls from is there's something called I think it's called image rehearsal therapy or IRT. Possible some of you guys may have heard of that. And then there's also something that's called like exposure and rescripting. It's ERRT, exposure rescripting something therapy. So CBT for nightmares kind of combines those two. And so here's something that you can do if somebody is having nightmares. Maybe you select a particular nightmare that's really bothering them. And it could be the one that happens the most frequently. It could be the one that was most recent. It could be the one that's most severe. I mean, there's really any, there's no rules about which one's the right one, which one's the most distressing. But you actually have the person. So it's both exposure and rescripting. So you have the person write out the narrative of the nightmare and write it out in present tense as if it's happening. So I do this, and then this happens, and then this happens, and then I say this, and then this person does this, and then write it out in present tense. And then they read it out loud to you. This is probably going to increase anxiety or distress. It's not going to be the most fun you've ever had. But really, the point of it is it's an exposure. And so what's happening in the nightmare is they're getting just slammed with it in the middle of the night when they're dead asleep and they're not equipped to deal with it and they're super vulnerable. And also overnight, we don't have like our executive functions, part of our brain is not super on it overnight, whereas it is during the day. We're more with it during the day. And so you're engaging with the nightmare material, but you're engaging with it in a way that you're in control. You're facing it during the day when you have all of your mental faculties and you're reading it out loud. And so there is this what'll probably happen is people will notice their distress gets higher. That's normal. It's kind of the point of exposure, really, is you kind of want the person to face it, see that their anxiety goes up, but then also notice that it will come down on its own. So they write it out, they read it out loud to you. Then that's the exposure piece. Here's the rescripting piece. Then you change it any way you want. They can change the beginning, change the middle, change the end, and change it however you want. So you can get really fantastical and have superpowers or magic or it doesn't have to be realistic. Or you can keep it very basic and realistic, but just have the person rewrite it such that in the new dream, they're safe, they're in control, they feel better about themselves. So it might be I'll give just a few examples. One of them was the recurring nightmare was about a sexual assault. And so the person's vision, their rewritten dream was they grew up and blew up and became a giant. And then they just stomped on the people that were doing the assault. Or that they were magic and they could make them disappear. But then I've also seen people rewrite the script to the police show up and they stop it from happening, or the people that are doing it change their mind and say, never mind, I don't want to do this. So you can get really fantastical. You can keep it real basic, but just change it such that in the new dream, there's more safety, there's more power, there's more control. Um, and then they're going to read the new dream aloud to you. And then what they're going to do for like the next week or two is before they go to bed, just visualize the new. You may have them practice this in session before they go. Just have them sit and close their eyes and just visualize the new dream. And then every night before they go to bed, they're going to visualize the new dream. And usually people don't start having the new dream. That's not common. But what does happen is it changes the nightmare. They stop, and I know this might sound, I mean, maybe some of you guys may have heard of this, but if you've never heard of this, it might sound like there's no way this can work. Like it sounds kind of ridiculous. But what tends to happen is they either maybe wherever the bad dream is, they stop having it, or it changes so dramatically that it's not distressing. Like I had somebody go from a dream about kids dying to having dreams about like she sent the wrong email at work. Like just silly, super low stakes. So and don't rehearse the nightmare, don't visualize the nightmare. So we're facing it here. And then you're going to read, and then you're going to visualize the new dream. It might take a couple, again, it might take a couple of weeks of having to kind of do it over and over. But we think what's happening is you're just giving your brain a different path to take at night. And I have seen this work. I have seen this change. Either they stop having whatever the awful dream was, or the dream just changes so dramatically that it doesn't bother them anymore. Okay. All right. So now we're going to be on this topic for kind of a while. I want to really do a deep dive into the circadian rhythm, and then also talk about there's a few different types of circadian rhythm disorders, and kind of talk about what those look like and distinguishing them from insomnia, because some of them can really look like insomnia. So, to talk about circadian rhythms, it's helpful to kind of pan back a little bit and just talk about biological rhythms in humans. And humans have a lot of different biological rhythms, and we can classify them in three categories depending on how long it takes to do one full cycle of the rhythm. So we have ultradian, circadian, and infradian. Ultradian is less than 24 hours completing a full cycle. So this is stuff like the stages of sleep that you cycle through. That's ultradian. Or your appetite, kind of states of hunger and fullness. That's an ultradian rhythm. So that's less than 24 hours. Infradian is more than 24 hours to complete the full cycle. So good examples of this are things like the menstrual cycle or pregnancy. So ultradian, less than 24, infradian, more than 24. Circadian is about 24, like circadian is from the Latin for about a day. And circadian rhythms are about 24 hours. And so your sleep wake cycle is on a circadian rhythm, your body temperature is on a circadian rhythm, and your melatonin production, among other things, are on a circadian rhythm. But those are some of the big ones. Here is just a visual of kind of all the different things in humans that are on a circadian rhythm. This up here should say 12 a.m. So this is midnight and this is noon. So for your typical adult, let's say it's 6 a.m., the sun's starting to rise, they're waking up around 6 or 6:30. Then their blood pressure shoots up. It's the sharpest rise of the day. Their melatonin secretion stops hour and a half after they wake up. They hit their highest alertness at 10 a.m. This might be different for different people. And then your coordination, your reaction time, your muscle strength, your blood pressure, all of those things are on a circadian rhythm. This person is hitting their highest body temperature at 7 p.m. Some people it's going to be later, like teenagers just spin all this later. Old people spin it all earlier. It's all the same stuff. They're just going through it at different times. This person, their melatonin secretion starts at about 9 p.m. So they're probably falling asleep about 11, 10:30, 11. We fall asleep like an hour or two after our melatonin secretion starts. This person's hitting their deepest sleep at 2 a.m. Their lowest body temperature is at 4:30, and then they wake up and the whole thing starts all over again. So this is kind of what everyone's circadian, for the most part. Now, I mean, babies. We'll talk about like babies' circadian rhythms. They don't really have a circadian rhythm, but all the rest of us, we go through these things over a roughly 24-hour period. Some people's are skewed a little later, some people's are skewed a little earlier. There are a couple of disorders where this, like dementia, for example, this process will start to break down. People with dementia will start to lose their circadian rhythm, and they're falling asleep and they're waking up at really irregular times. But for the most part, this is what that looks like. And circadian rhythms are really everywhere. Every known living thing on the face of the planet has a circadian rhythm. Like when we talk about just animals that are nocturnal, that's their circadian rhythm is to be nocturnal. Humans are diurnal, just the opposite of nocturnal. So every living thing on the face of the planet has a circadian. Oh, I just saw a typo there. Has a circadian rhythm, and every single cell in your body has a circadian rhythm. And then you've got this, it's called the suprachiasmatic nucleus. It's this tiny little, you can barely see that little speck of green. This is about where it is in your brain. That's the master clock. And that's the thing that takes care of kind of syncing up all the cells in your body and getting them all on the same schedule. So there's internal synchronization. We need all of you kind of synced up and being on the same schedule. But there's also external synchronization, which is how well are you syncing up with the world, the demands of your life, your schedule. So the suprachiasmatic nucleus is taking care of syncing up everything inside. A lot. So sometimes that's the issue. Sometimes the internal synchronization is breaking down. Other times the problem is the external synchronization. So external synchronization is just how well does the time that you want to sleep and the time that you want to wake, how well is that matching up with the demands of your life? So there's a lot of talk about should schools be starting later, because early start times and teenager circadian rhythms don't really line up. And so there's a lot of talk about should school be starting later? Because for a teenager to get up at 6 in the morning, it would be kind of be like telling a 45-year-old to get up at 2 or 3 in the morning. Like it feels like the middle of the night. So that's sometimes the problem is external synchronization. Sometimes your circadian rhythm is fine. It's just not linking up with your schedule. And a particular rhythm isn't inherently bad or disordered. Some people are night owls. It's okay to be a night owl. There's kind of this attitude out there that it's better to go to bed early, that's what's healthy or proper or mature or whatever. And so a lot of the work I do with people is destigmatizing, hey, it's actually okay if you are a person who stays up a little bit later and sleeps a little bit later. It doesn't make you lazy, it doesn't make you irresponsible, it doesn't make you unhealthy. The problem is just if you can't fall asleep until late and then you have to get up early for work and then you're not getting enough sleep, that's a problem. But the fact that you sleep on a little bit later schedule, if you could just build your schedule around your circadian rhythm, which some people do. Some people just will take like night shift jobs or later shift jobs. Um, they can sleep okay if they can just sleep on their preferred schedule. So what really makes it a disorder is how it's impacting your life. So then there's kind of this question of how does your brain know what time it is? And the word, we use a German word in the sleep world, Zeitgeber, I think is how you'd say it. It's German, it means time giver. It translates to time giver in English. So Zeitgeber or time givers, those are all the things in your environment that help tell your brain what time it is. And is it light or is it dark? Should you be awake? Should you be asleep? What should you be doing? We call them Zeitgebers or time givers. I'm going to say time givers because I'm probably not getting the German right. But the most impactful Zeitgeber or time giver is the light dark cycle. So humans are, for the most part, we're meant to be awake and alert when it's light and sleeping. Like we're not nocturnal. There are people who skew a little bit earlier or later. And there are, I mean, there are people with who are like really delayed that they start keeping like vampire hours. But generally speaking, humans are not, we're not meant to be nocturnal. And so light is like the biggest cue to our brain as to what time it is. So this is why the time you're getting out of bed also tends to disrupt the time that you're getting light. And that's one way that confuses your brain. Or if you travel across a bunch of time zones, the timing of when you're getting light versus dark is shifting. And so that's why it's like the light, your light exposure schedule is changing. Light goes directly to that suprachiasmatic nucleus. And we use the word entrainment to refer to trying to sync, we call it entraining the circadian rhythm. So it's trying to sync up my internal rhythm with the world. And light is going to entrain it whether you want it to or not. So for people with insomnia, I don't think the screens are a huge factor, but for people with circadian rhythm issues, and we're nowhere near done. We're talking a lot about the circadian rhythm. People with circadian rhythm issues, I think for those people, light exposure. So these are really the people that might want to consider like the blue blocker glasses in the evenings, trying to get more light exposure in the morning, because their whole problem has to do with that internal rhythm. Insomnia is about like learned behaviors that have become habits. But your circadian rhythm, that's more intrinsic. Like a lot of it's genetically determined. At least some types of circadian rhythms are genetically determined. So light is going to shift it whether you want it to or not. So light is probably the most impactful time giver. Another time giver is melatonin. So melatonin it's naturally occurring. We all have it. It's a hormone that the pineal gland in our brain produces at night. And light is a stronger time giver than melatonin. So light will actually suppress melatonin production. So like for teenagers, I think for those people, for those guys, it's a really good idea to try to have like, if they want to stay up and, look at, gaming or looking at whatever, and like at least get some blue blocker glasses. They should be orange. They're going to make everything look orange, but get some blue blocker glasses because that light is pushing you later and you're already too late. We need to push you earlier. But that light is going to push you later. Light will suppress melatonin production. And there's something called your dim light melatonin onset, or we call it your DILMO. So this is that thing at some point in the evening, usually it's like as it's starting to get dark outside, your brain will start to produce melatonin. And that production of melatonin, it's a time giver. So it's letting that suprachiasmatic nucleus that syncs up all the internal stuff, it's letting it know, hey, dark is coming, sleep time is coming soon. Most people are going to fall asleep a couple of hours after their DILMO. So again, your average teenager, much later DILMO than your average old person, much earlier DILMO than a typical just kind of like middle-aged adult. So a little bit more about melatonin, because a lot of people take it for insomnia. So they use it as a hypnotic. And a hypnotic is a sleeping pill. So they use it as a sleeping pill. They take it with the idea that it's going to induce sleep. And really, melatonin is not a hypnotic. Like Ambien's a hypnotic, Lunesta's a hypnotic, Sonata's a hypnotic. We could list a bunch of other, but like those types of medications, those are hypnotics. I mean, alcohol is kind of a hypnotic. Those are going to knock you out and make you sleep. Melatonin is not going to knock you out and make you sleep. rather than calling it a hypnotic, it's really what's called a chronobiotic, and chrono means time. So melatonin, the purpose of melatonin is you can use it if either the circadian, you can use it to regulate. So people will use it when they travel. You could use it to deal with jet lag because you're having to sleep on different schedules. People will use it for jet lag, really any sort of circadian rhythm issue. So melatonin can either regulate the circadian rhythm or it can shift it earlier or later. Mostly shifting earlier. There's not a lot of evidence that we can use melatonin to shift people later. And circadian, so melatonin is useful if there's some issue with the person's circadian rhythm. And circadian rhythm disorders, they're all treated with some combination of properly timed light exposure and properly timed melatonin dosage. So, not helpful for insomnia, but often helpful for circadian rhythm disorders, melatonin. This is what the circadian rhythm tends to look like over the lifespan. So this is going, let's see, I think I had a error on this, but so 6 p.m. to midnight to 6 a.m. to noon, and then back to midnight. So a newborn, as I mean, if you've ever had a baby at home, they don't have a circadian rhythm. It is irregular, inconsistent. They sleep a lot, but it's very like up and down and up. There's no rhythm to it. Newborns don't have a circadian rhythm. The circadian rhythm forms over the first few years of life. So by the time a kid is a year old, their sleep is starting to consolidate a little bit more. They're still gonna be like they're a pretty long sleeper, and your average 1 year old is probably taking a couple of naps in the afternoon. And then a 4 year old, the rhythm is consolidating more. They're starting to become more of like the monophasic sleepers that most of us are. So it's one long block, but a 4 year old's probably still taking a nap sometime in the afternoon. And then a 10 year old. By the age of 10, most kids are not taking naps anymore. They're sleeping in one block. It's a long block. So I tried to this isn't like perfectly exact, but I tried to make the blocks like long or short, depending on how long or short people of this age sleep. But 10-year-olds are long, kids need a lot of sleep. Their brains are developing. Generally speaking, the older we get, the less sleep we need. So babies, little kids, they need a lot of sleep. So that's the 10-year-old. As we're moving into adolescence, it's getting shorter. They're not sleeping as long, but notice how it's pushing later. Notice how now they're staying up much later. They're wanting to sleep. They're still not sleeping super late, but they're sleeping. It's everything's pushing later. And then look at older teen, much later. Not uncommon for older teens to have a really hard time. I mean, this is 12 a.m. This is probably like 2. That's not necessarily the time they fall asleep on average, but much later. Falling asleep much later, waking up much later. And then as you get into young adulthood, the rhythm will start to advance. So it'll start to back up as you get older and then into middle age and then older adult. Your time to bed and time to wake up will generally shift earlier, although not always. I have definitely seen seniors who are delayed. So this isn't like 100% for everybody. And I'll just talk really quickly about how do you know if it's just normal teenager versus some kind of a disorder. And you really want to look at how disruptive it is to their life. So your typical older teen, they want to stay up late. They're not a morning person, but they're going to be able to kind of bumble through it. They're going to be able to go to school. They're going to be able to get up and go to band practice, or if they're a young adult, get up and go to their job. Like they're going to be able to muddle through. But with a circadian rhythm disorder, what you're going to see, it's typically a young adult who's living at home, who's not in school, who's not working. They tried to do college, they just couldn't make it work because they couldn't get up and get to class. They tried to work a job and they got fired because they just kept showing up late or they couldn't get to work. They oversleep. These are people who you'll schedule them an appointment. Like my delayed people, I never schedule them in the morning. They're only scheduled in the afternoon. And even then, they'll oversleep a 3 p.m. Like they'll oversleep a 2 o'clock, 3 o'clock. Um, so that's really it's people who it's affecting their life. Like they're not able to hold down a job, they're not able to do school, they're not launching. It's kind of the difference between a disorder versus just a normal teenager that wants to stay up late and sleep late. So here are we're going to talk about 5 different circadian rhythm disorders, and then we're also going to talk about jet lag. We'll talk a little bit about jet lag. Jet lag is no longer considered a disorder because it's just considered to be a fact of modern life. But there is guidance around how to adjust to eastward and westward travel. So I'll share that with you guys. But there's to start over here, there's something called delayed sleep wake phase disorder and advanced sleep wake phase disorder. These look a lot like insomnia. Delayed sleep wake phase, their complaint is going to be that they can't fall asleep, that it takes them hours to fall asleep. And these are usually people like they can't, it's 1 a.m. or later is the time they're falling asleep. And they cannot for the life of them get going in the morning, like 9 a.m. or later is the time. And it may be much later. I have people that are sleeping 6 in the morning to 4 in the afternoon. They tend to be long sleepers. And kind of the difference, how you distinguish this from insomnia, is if a delayed sleep phase, if the world would just accommodate their sleep schedule, they would be fine. Like if they could just sleep from 2 in the morning to noon, and that was their schedule, and their day didn't start till later, they don't have a sleep problem. Versus insomnia, they're going to have trouble sleeping, kind of even if they try to go to bed at a different time. And the tricky thing is that you can have both. You can have, because this is genetic. I mean, your circadian rhythm is largely genetic. It's kind of like your hair color, but you can develop a pattern of insomnia on top of the circadian rhythm disorder. So these might be the these might be the types of cases to refer out to somebody like me, because I can kind of help make that distinction between what's insomnia, what's circadian. Is it both? Maybe it's both. But delayed sleep phase, they just fall asleep super late, wake up super late, but they sleep really well if they can just sleep on their preferred schedule. Same with advanced, just push the other. These are people who are falling asleep at like 7 o'clock in the evening, and they're waking up at like 3 in the morning, and they're ready to go. And it feels like, the middle of the, not the middle of the day, but 3 in the morning doesn't feel like the middle of the night to them. This is almost always going to be an older person. And you just don't see as much fallout with advanced. With delayed, these are people, they can't get to school, they can't get to work. Advanced, it's more like they just don't have much of a social life, which sucks, but it's not it's more disruptive to your life if you can't get to school and can't get to work. Then you can't go to happy hour. And then shift work disorder. So this is just like if somebody has to work a shift that is misaligned with their natural time they want to fall asleep and time they want to wake up, that becomes a disorder. These two are not as common. We're not going to spend a ton of time on those, but like there's something called non-24, and you're going to see this if you work with blind people or people with a particular type of brain injury. Their brains do not respond to light. And so what happens is every day they go to bed an hour later and wake up an hour later. And then hour later, hour later, hour later, hour later. They just kind of like go around the clock. So what's happening is the light is not getting to their brain. And light is one of the things that kind of helps keep us like actually we would all do this if we didn't have exposure to light. If you put us all in a cave for 30 days, we would all start to do this. And then irregular, this you're going to see if you work with dementia. I think like intellectual disabilities in kids, they can have this irregular. But these are the circadian rhythm disorders. So I want to show just a little bit about what the sleep phases look like. So if a normal, this block is a little long. So your normal kind of typical person falls asleep sometime between 10 and 11 p.m. and wakes up sometime between 6 and 7 a.m. That's the typical circadian rhythm. There are people who skew 1 to 2 hours later. We call them night owls. They're normal. There are people who skew like 1 to 2 hours earlier. We call them morning larks or early birds. They're normal. And then there are people that it's like 3 to 4 hours later or earlier than that. That's where we start calling it a disorder. So delayed sleep phase, same block, just pushed much later. And advanced, same thing, just pushed much earlier. And then irregular. So these are just people who, if you add up the total amount of sleep they're getting in a 24-hour period, it's going to be a reasonable amount. It's going to be like 7 to 8 hours. They're just getting it in these little. So you see this in dementia, the circadian rhythm starts to break down. And then non 24, this isn't really depicting it. This isn't really showing much of anything, but it's just, it moves ahead by an hour every day. So really specific populations that you're gonna like. I don't really see a lot of these, and I specialize in sleep. So let's talk about delayed sleep wake phase disorder, because people are never gonna say, I have delayed sleep wake phase disorder. They're gonna say, I can't sleep. I can't sleep. I can't fall asleep. It takes me forever to fall asleep. They might say I have insomnia. And of course, the difference really is just with these people, if they could just sleep on their preferred schedule, they're good. Whereas somebody with insomnia, even if they try to sleep on the right schedule, that's not the only thing that's going on. So typically they're falling asleep sometime between 1 a.m. and 6 a.m. So if somebody is like regularly not falling asleep till somewhere in here, and they wake up 10 to like way later, like they cannot for the life of them get going before like 9 or 10 in the morning. They're going to tend to feel super alert in the evening. And what's happening with these people, why this is a problem, is that school starts early, work starts early. If they have to keep like normal hours, like if they could just keep their hours, they're good. But if they have to try to keep normal people hours, then they're not going to get enough sleep, because they're not, let's say they're not falling asleep till 4 in the morning, and then they have to get up at 6 to like get ready for school. So you're going to see that they're not going to get enough sleep, and then they're going to be falling asleep during the day. Usually people with insomnia, if it's just insomnia, they're not falling asleep during the day. They're not sleepy. Um, they're fatigued. They're not. They think they're going to fall asleep. People with insomnia are always like, "Oh my god, I almost fell asleep." They're not falling asleep. Delayed people, they're going to be super sleepy in the morning and just alive in the evening. They just get more alert as the day goes on. Here's kind of what you can, with adolescents, you're going to see a lot of like a lot of trouble, like beyond what most adolescents struggle to get out of bed in the morning, but most of them can kind of bumble through it. These are they just cannot. They tend to be heavy sleepers. And then in adults, there's just a lot of like trouble, like they can't make it to work. So then they have financial struggles. Also, there's a lot of like, but in a marriage, if you have one spouse who's delayed, then it seems to fall on the other spouse to get up in the morning and like get the kids going and that. So then there could be this resentment about, why am I always the one that's having to get up and deal with the kids? So typically their dim light melatonin onset is later than 10 p.m. And then remembering that we fall asleep like 1 to 2 hours, and it might be much later than that. So for these people, taking a little bit of melatonin, and it's like 4 hours before bedtime. It's way earlier. If the instructions say take it at bedtime, but it's not a hypnotic, so why would you take it at bedtime? The instructions are wrong. You want to take it 2 hours before your DILNO, which is usually 2 hours before you fall asleep. So whatever time you're falling asleep. And then you can move it earlier if you want to try to get the person going to bed earlier. And again, with this delayed sleep phase, if they can just keep, and some people do this, like some people, they take night classes, they work second shift jobs. Like that is one option. They work in food service or they work in an industry where they can work those later hours and they don't have to get up early. So sometimes that's an option. Um, but there is, so here's the treatment for delayed sleep wake phase disorder. So this is what I do with my people who are delayed. Once I've kind of determined, okay, this is a phase delay. With insomnia, like you always want to treat the insomnia first, then treat the phase delay. But I have them keep a sleep diary for 2 weeks, and I tell them go to bed when you want to, get up when to the extent that you can, go to bed when you want, get up when you want, because I really want to be able to determine what is your body's preferred sleeping schedule. So keep a diary for 2 weeks, write down the time you fell asleep, like really like the time you fell asleep and the time you woke up are the most important. And then I average those out. And I'm like, okay, so you're typically falling asleep at 2 in the morning and you're typically waking up at 10 a.m. So then we set that as your schedule, 2 to 10. And you keep that for 4 days and you get out of bed at 10. I don't care if you feel like crap. I don't care, like come hell or high water, you are getting out of bed at 10 and get an hour of sunlight when you wake up. So light on either side of your temperature minimum is either going to push you earlier or later. So this is why for these people, light in the evening will tend to push them later because if their let's say their temperature minimum is 7 in the morning, um, light in the evening or light kind of in the wee hours of the morning, that's going to push them later. But if we can get you light after your temp, like you get out of bed at 10, get an hour of sunlight is best. If they can go outside and walk around and be out in the sun for an hour, that's the best case scenario. Next best case scenario is sit next to a big window. But get out of bed, stabilize the bedtime and the wake time, get an hour of light when you wake up. And then we just walk it back until like, well, I'll ask, okay, what time do you want to be going to bed? And what time do you want to be getting up? And they'll tell me. And so we just walk it back 30 minutes at a time. And you get the hour sunlight. And then we just walk it back until we get to the right time. And then I tell everybody it's kind of like coloring your hair. You have to keep it up because you are all, if you're delayed, it's always going to want to delay. A lot of it is genetic. And so it's just like if you color, you have to stay on top of coloring your hair. So just a thing to keep in mind that they may have to keep this schedule for the foreseeable future. Like they might just not be able to be super erratic in their bedtime and wake time the way people who don't have circadian rhythm issues do. So that's what that looks like. Working with the circadian phase delay. And so what I'll say just for you guys, because you may not want to like go to this length, but trying to get like light exposure when they first wake up and trying to not have light in the evening. So talk about advanced. I don't see a ton of this, and I don't know if that is because it's just not that common, or if it's because there's not as much of a stigma associated with going to bed early and waking up early. Like it just people don't. I have more people coming in and they're like, I can't get to bed at a decent time, and I can't fall asleep at a decent time, and I can't wake up at a decent time. I don't tend to have a lot of people that are like, oh, I wake up too early, but sometimes I do. So these people are going to fall asleep, like left to their own devices. They fall asleep like between 6 and 9 p.m. And they wake up between 2 and 5, like rested, ready to go. They're going to tend to be very alert early in the morning. And then they're going to start feeling, because their afternoon is like our evening. They're going to start feeling super sleepy in the afternoon toward the early evening. Um, and again, it can look like insomnia because part of insomnia might be that you wake up too early and you just can't get back to sleep. So again, you're looking at, is it just a scheduling issue? Like if they could just sleep on the schedule they prefer, would the sleep problem go away? or would they still have a sleep problem? And of course, you can have both. Or obviously, this can happen in depression. I think the difference is these people, like, they sleep pretty well. They just can't sleep as long as they want. Whereas typically with depression, people will say they're not sleeping, like the quality of the sleep they're getting isn't that great. It's pretty rare that you're going to see this in not an elderly person. So these are the people that are going to say they can't fall asleep. So we don't have as much. um, Melatonin is actually not recommended. We know we can use melatonin to try to like pull somebody earlier in terms of when they fall asleep, but it's really not recommended. It hasn't been shown to be that helpful for pushing people later. And so sometimes you can do some light in the evening from 7 to 9. Like these might be the people that get light boxes. But it's what's called a weak recommendation. That's the American Academy of Sleep Medicine. They have like strong recommendation, weak recommendation, and no recommendation. And weak recommendation just means it's better than nothing. So really for these people, it's scheduling. It's really trying to be like, okay, so this is how your body seems to want to sleep. How can we try to structure your life around this? And just know that you are going to fall asleep earlier and you're going to wake up earlier. So how do we just try to build your life around? You can try doing some light in the evening, but it's kind of mixed as far as like how helpful it is. So with these people, a lot of it is just yeah, how do we kind of like almost seeing it like a chronic illness. Like we're not going to fix it, we're not going to cure it, but we can try to figure out how do we build you quality of life around this. And this is just you're not going to see unless you work with like the geriatric population. Um, Probably not going to. Mostly, what you're going to see is the phase delay people. So I wanted to show you. This is kind of all three of these, like delayed, advanced, and then normal, and just kind of have them all laid out comparing the three. The solid line, this is the kind of normal or typical. So, and this is body temperature over here on the edge. So notice that this starts about 12 noon, da da da, and then oop, here's the circadian dip. So they have their little dip. It's sometime between like 3 and 5 in the afternoon. That's when most of us are having our dip. And then we go into what's called awake maintenance zone. So this is a chunk of time where it would be like physiologically impossible for you to fall asleep. So for this person, it's from 6 p.m. to 9 p.m. And then once we come out of 9 p.m., is notice that like their body temperature is high here. So that's important. Your body temperature needs to drop for you to fall asleep. So now it's dropping. They're probably falling asleep. Here's their temperature minimum. It's 4 in the morning, and then it starts to rise, and then oh, here we go. They're waking up at like 7 o'clock. Now they're in another wake maintenance zone. So then the little squares, this is a delayed person. So same process, just pushed later. So notice they are not hitting their circadian dip until their circadian dip's a little bit later. And then their wake maintenance zone. So their wake maintenance zone starting at about 8 p.m. It's going till midnight. So this person trying to go to bed at 10 is like telling someone else to go to bed at like 7. It's way too early. So now they're finally dropping out of it. Okay, midnight. So starting at midnight, like your average phase delayed person, they are never going to fall asleep. Certainly never any earlier than midnight, probably not earlier than 1 a.m. And then their body temperature drops just like the other person does. SOI means sleep onset insomnia, because that tends to be their main complaint. Here's their temperature minimum. It's about 7 in the morning. Then it starts to rise. So they're probably waking up at like 10. And then the dashed lines, this is an advanced person. So same thing, just everything's earlier. They're already hitting their circadian dip, like maybe just after lunchtime. And then they're going into that wake maintenance zone, but then they're dropping out of it at like 7 in the evening. So their body temperature is dropping. Here's EMA stands for early morning awakening. they're hitting their temperature minimum at like 2 in the morning. So they're probably waking up at like 4. And then the whole, so it's all the same, exact same process, just pushed later or pushed earlier. Okay, so I'll just talk a little bit about, I won't spend a ton of time on these. I don't see a lot of these, and you're really only going to see them if you work with very specific populations. So this is some types of brain injuries, dementia, kids with neurodevelopmental disorders, but this is where you have 3 or more sleep episodes in a 24-hour period, but they're sleeping a reasonable amount if you add it all up. And so the treatment for that, and I've never treated anybody for this. So this is what I know of the treatment. They do use melatonin for kids and people with neurological disorders. Melatonin is not recommended for elderly people. So that's just another thing to keep in mind if you have elderly clients that are um, taking it for sleep. The American Academy of Sleep Medicine does not recommend melatonin in the elderly population. And then light. So again, it's these time givers, light, melatonin, and then structuring their day. So really trying to get these like time givers queued up so that we're consolidating the time that they're sleeping. And then non-24, you're going to see this in blind people or people with particular type of brain injury where their brain doesn't respond to light. So all of us would do this if we were deprived of light. You stuck us all in a cave for a few weeks. We would just start to like run around the clock. So it's like every day it's like a little bit later, a little bit later, a little bit later, and it just kind of runs around the clock. So the treatment for that is it's melatonin. They don't respond to light, so we don't have that at our disposal. And I've actually never treated anybody for non. I'm familiar with it. I'm familiar with the treatment, but I've never treated anybody for it. So I don't know that this stuff is even making it to like behavioral people. But that is it's melatonin. Okay, so I want to talk about shift work and what we call shift work disorder. So this happens if you're working a shift. So usually it's a shift that starts anywhere from 6 p.m. to 4 a.m. And your rhythm does not naturally align with that shift. So some people will try to take a non-traditional shift if they have sort of a non-traditional circadian rhythm. But if you have a quote unquote normal circadian rhythm and then you're being asked to work a shift, then that becomes a disorder. So here's what's going on. Your circadian alerting signal is high during the day when you're trying to sleep, and you're super sleepy and your brain is making melatonin at night when you're supposed to be awake. And really the worst case scenario is kind of the way we tend to do it. So if somebody is going to work night shifts, if they could just always work a night shift, like to have it where it's like you're on days and then you're back on nights and then you're back on days and then you're back on, that's just gonna suck. There's no way to make that not suck. There is a protocol for shifting people to the like the night shift type of schedule, but it's really they need to be working at least 2 consecutive weeks of night shifts to make it worth their while, because the circadian rhythm is really slow to shift. So there's just no, I mean, there's just like, or the other problem is people will try to keep normal, like if they're not working, they keep normal hours, which of course they want to keep normal hours. They want to see their friends. They want to see like it all makes sense. Really, humans are not, should not be working night shifts unless you are like a phase delayed person. So it's a lot of it is just gonna suck. There's a way of making it suck a little bit less, but just knowing that if you're bouncing back and forth from day to night, that's gonna mess anybody up. Or if you're working night shifts, but then you're trying to keep normal hours when you're not working, that's gonna mess anybody up. So kind of the first thing I do ask people is like, can you get off night shift? I understand that may not be possible for everybody, But that's the first intervention is, can you get off night shift? But here's some stuff you can do. So you could have them take a little nap, a little 15-minute nap, either before their shift or early in their shift, if that's feasible. And then they're just trying to get as much light as they can get when they need to be alert, and as much like dark as they can get when they need to be asleep. So try to get light exposure early in the shift, try to get light when they're at work. And then as they're driving home, have them wear sunglasses or blue light blocker glasses, and then take some kind of, it could be melatonin, or it could be a sleep aid before you go to sleep. And then people will try to use caffeine, or even I've seen it where people are, modafinil is a prescribed stimulant medication. I've seen that prescribed for people to help them be alert when their body is like, no, we need to be sleeping. So these are some things you can try to do, but just knowing that shift work just sucks and it's bad for people, and we can make it suck a little bit less. But in a perfect world, and I know that again, there's certain professions where people need to work nights. In a perfect world, no human would be working a night shift unless they're a night owl. Okay, so talk about jet lag. About the fastest you can expect to shift your circadian rhythm is about an hour a day. That's about the fastest we can expect that to shift. So you can imagine if you're traveling 7 hour time difference, theoretically it's going to take you about 7 days to adjust. And what's really going on is that why travel messes us up so much is it we're kind of used to getting light and not light at certain times of day. Travel's going to alter that. For most people, eastward travel is more difficult than westward travel. So here's just some guidelines if you're going eastward. I'll also just say the last time I went to Europe, I actually tried, there's this stuff called Fly Kit. It's kind of expensive. It's about $100 for like the whole kit, but it's this whole plan where it tells you like when to get light and when to not get light, and when to eat and when to take a nap. And then there's like supplements that they have you take. One of them is melatonin. There's a couple of others. Now, I don't know if it was placebo or if there was something to it, but the second Europe trip was much easier than the first Europe trip where we didn't use Fly Kit. So that's purely anecdotal. That's just my experience. But we had a good experience. So that might be something to consider. But the American Academy of Sleep Medicine does have some guidelines. It's kind of a pain. Most people decide not to mess with it. But if you're going east, 3 days before you go, start walking your bedtime forward. And then take melatonin about 5 hours before your typical bedtime. Get lots of bright light in the morning. When you get to your destination, try to avoid bright light in the morning, get light in the afternoon. And the flight kit thing actually kind of walks you through. It'll tell you, like, it comes with the blue blockers, when to put them on, when to get light. Most people, when they're traveling west, it's not as difficult because you're gaining time. But if going westward is difficult, before you leave, try to get a couple of hours of light exposure before bedtime. Push your bedtime back 4 hours. That should delay you about an hour and a half. And then when you get to your destination, try to avoid light early in the day. Try to get a bunch of light in the evening because we're trying to push you later. There's timing of when to take melatonin, like 10 a.m. and 12 p.m. At where you are before you leave. So you can see where this is it's a pain in the ass. Like, I've never done it. I don't know anybody that's done it. I shared this with people, and most people are like, I'm just going to tolerate the jet lag because it's a pain. But there's some guidance around when to take melatonin, when to avoid bright light. Okay. All right. So that's everything with the circadian rhythms. Talk a little bit about sleep apnea. So, with sleep apnea and with insomnia, it's really different to make the distinction between tired and sleepy. And so we talked about that a little earlier. People with insomnia, they're not very sleepy. They're tired. They're tired but wired. People with sleep apnea, they're sleepy. These are the people that are falling asleep in your waiting room. These are the people that are snoring on the airplane. These are the people that are falling asleep unintentionally during the day. And so there's a tool called the Epworth Sleepiness Scale. It's very easy to find on the internet. It's an objective, or I guess as objective as we can be, of daytime sleepiness. So it asks people, how likely are you to fall asleep on a typical day doing 8 different activities? And it's like sitting and reading, sitting in the car, sitting quietly after lunch. And you can add them up. And if it's greater than 10, then we would consider that to be like problematic or excessive daytime sleepiness. So if somebody is excessively sleepy during the day, it could be a lot of different things, but the most likely culprit is sleep apnea. And sleep apnea, most sleep apnea is obstructive. There's obstructive and there's central. Obstructive is much more common. So I think I think okay, yeah, I do have some definitions. So we'll get to those. So there's also a tool called the stop bang. Again, very, very easy to find on the internet, but it's got some questions that you can ask. And I think if they say yes to 3 or more, then you would recommend. So I would say if they score over 10 on this excessive daytime sleepiness, and then maybe you want to do the stop bang, and if they say yes to 3 or more, then I would recommend referring somebody for a sleep study to rule in or out sleep apnea. And the gold standard, so sleep apnea is really about its breathing. So the gold standard treatment for sleep apnea is um, CPAP, which stands for continuous positive airway pressure. And there's all kinds of different, there's all kinds, like there's CPAP, there's all other kinds of different PAPs. Like I could get into all the different types of things we can use to treat insomnia, but mostly it's this CPAP. What's important to remember is that CPAP is a breathing treatment, not a sleep treatment. So CPAP will help you breathe. So CPAP, it uses pressure to basically like splint the airway open. Because what's happening is people's airway is closing and they stop breathing. And then their brain is like, oh shit, my human's not breathing. Oh my God, I gotta wake him up, wake up, wake up, wake up. So they wake up and they're like, like gasping for breath. And then they start breathing. And then they fall back asleep. And then the whole process starts over again. It is possible to have both sleep apnea and insomnia. And so a lot of the time people get their sleep apnea diagnosed, they're recommended a CPAP, and then they stop wearing it for any number of reasons. But sometimes the problem is that they also have insomnia, and the insomnia also needs to be treated. Like the CPAP is not going to treat the insomnia because you don't have insomnia because of breathing. But also, if you have insomnia, I really can't think of a worse situation than like, oh, put this weird thing on your face and like try to sleep. Like, it's like the adherence rates for CPAP are pretty abysmal. And I think there's a couple reasons for that. One, I don't know that a lot of sleep clinics are, I just don't think a lot of places, I don't want to throw other providers under the bus here, but a lot of sleep clinics are just not doing a good job of explaining to people what's going on. Like, I think if you sit down and take the time and be like, here's what this means, here's what this means, here's what this means. So I've started having people send me their sleep study and I will go through it and say, here's what this word means, here's what this means, here's what this means, here's what they're telling you to do. And for a lot of people, it's like if you just explain, here's what, because a lot of time it's like, oh, you need to sleep out, and that's it. And so you want to tell people to be a pain in the ass if they're getting fitted for a CPAP and it's not comfortable. Be a pain in the ass with the doctor, with the medical supply company. Keep going back until you get something that's comfortable. There's 10 bajillion different types of masks. If it's leaking, if it's not comfortable, like you got to be a squeaky wheel. And so I'm like, stay on them because you need something that's comfortable. So anyway, that's just a little piece of advice if you're working with people with sleep apnea. But an apnea is a cessation in breathing that lasts at least 10 seconds. And then you can also have what are called hypopneas, which is a reduction in breathing that lasts at least 10 seconds. And then people with sleep apnea will have what's called an AHI, or an apnea hypopnea index. This is the number of either apneas or hypopneas that are happening per hour of sleep. Mild is 5 to 15. 15 to 30 is moderate, 30 plus is severe. There's two different types of sleep apnea. Most of what you're going to see is obstructive, which is kind of how this, so you fall asleep, all your muscles relax. Something in your like you're trying to breathe, but your airway's obstructed. And it could be your tongue shifts. It could be that your airway is just super narrow to begin with. It could be your soft palate. It could be, I mean, any number of things, but something shifts, something's blocking the airway, you stop breathing. So your oxygen level goes down. There's increased effort to breathe. So then you wake up and then you start breathing and then you fall back asleep. A lot of the time, people with sleep apnea are not aware that they wake up. Sometimes it's the bed partner that is like, yeah, you woke up gasping for breath. Or a lot of the time, these people snore like bears. Like it's snoring that's like loud enough to hear through the door or through like reverberates around the house. Um, so that's kind of typically what's happening. Central sleep apnea is, that's not as common. That tends to be more secondary to like heart, if someone has like a heart condition. Or central sleep apnea is right, there's just no longer effort to breathe. Your brain is just like, it's cool, it's fine. We don't need to breathe. Like I think that's what happens a lot of the time with drug overdoses, like opioid overdoses. I think I might be wrong about this, but ultimately I think it's said like they just stop breathing. Central sleep is central sleep apnea. So mostly obstructive is what you're gonna see. So I wanted to share, here's a little kind of process if somebody is having trouble adjusting to their CPAP mask, like if they're saying that it's uncomfortable or they feel claustrophobic. So there's a step-by-step process that you can walk people through to kind of build them up to wearing it. And so I'll say, so don't wear it at night at all until we can get you comfortable in it during the day. So we're going to stop wearing it at night for the time being. And then you start out with just take it out of the thing, just hold it to your face. Don't turn it on, don't put the straps on, just hold it and do that until you can tolerate 5 minutes, however long it takes you to get to 5 minutes. Then put the straps on and turn it on and just sit there and do that until you can tolerate 5 minutes of that with it on. Then you're going to try to take a nap. Don't worry if you fall asleep, but just lay down, try to take a nap, try to just get a little spurt of sleep with that CPAP on. Then you get to wearing it at night. So you can kind of step somebody in if they're like, I don't want to wear this thing, it's uncomfortable. And then, of course, the other thing is to tell them to be a pain in the ass with the doctor and the medical supply company to get something that's comfortable because people will just take the first mask they get and it sucks and it doesn't work. And then they're just like, oh, well, um, yeah, that's just too bad. And then they stop. And then the insurance takes it back because they're like, well, you're not complying and you're not wearing this thing. And sleep apnea kills people. Insomnia really doesn't kill people. Sleep apnea kills people. Okay, so I wanted to now kind of finish this out talking about hypersomnia. If we're talking about the broad topic of hypersomnia, I want to look at just the like medical symptom of hypersomnolence. So this is hypersomnolence. It's excessive sleepiness. So if somebody's excessively sleepy during the day, it could be that they have sleep apnea, could be that they have a hypersomnia disorder. It could also be it could be drugs or alcohol. It could be a medication, could be another medical condition. Um, but this is hypersomnolence, excessive sleepiness. So like they're falling asleep when they don't want to. And sometimes with some types of hypersomnia, they're long sleepers that are just never satiated. So that's the symptom of hypersomnolence, which could mean lots of different things. And then some people who have the symptom of hypersomnolence have what we would call a central disorder of hypersomnolence. This is where hypersomnolence is like, that's the primary symptom, that's the disorder. So we have narcolepsy 1, narcolepsy 2, and then there's something called idiopathic hypersomnia, which is just, oh, you're sleepy all the time, but we don't know why. You don't have sleep apnea, we don't have narcolepsy. I don't know. we don't know. So standard care for these things is medication. It's typically going to be a stimulant A lot of the same medications that are prescribed for ADHD get prescribed for narcolepsy, also stuff like Provigil, Nuvigil. And then interestingly, GHB, which is colloquially known as the date rape drug, is a medication that's used to treat hypers. I don't know exactly how that works. And it's sold under a different trade name. It's like Oxy, now I can't remember. But anyway, a lot of people have really good, it's super interesting. A lot of people have really good results with that. Um, but even if they're properly medicated, there's a lot of quality of life issues with people who have narcolepsy, idiopathic hypersomnia. And so that's where we can come in. So with these, you really want to think of these are chronic illnesses. So like insomnia, you can cure it. Nightmares, you can cure it. I guess sleep apnea, you can effectively cure it if the person's wearing their CPAP. But hypersom, like this is a chronic illness. This is something that it's not going to go away. We treat the symptoms as best we can. We try to kind of build quality of life best we can, but this is not something that's going to be cured. So I'll talk about narcolepsy, and then I'll talk about idiopathic hypersomnia. And so narcolepsy, there's two different types. There's type 1 and type 2. Narcolepsy 1 has this unique symptom called cataplexy. And cataplexy, it gets portrayed in TV and movies as the person like falling down and like snoring, and like it gets portrayed kind of dramatically. It's not usually that. Like even this guy, like with his eyes closed, it's not even usually like a lot of the time people maintain consciousness, but it's just this, they might stumble. It's just a quick sudden loss of muscle tone, usually in response to a strong emotion. If they get really angry, if they get really amused, they might fall down the stairs if they're walking down the stairs. But if you're seeing somebody who's like, yeah, every time I laugh or every time I get surprised or every time I'm angry, I stumble, I lose my footing, it's almost like they look a little drunk for just like a few minutes. And then it doesn't last that long, but that's cataplexy. So if you're seeing that, recommend somebody go get a sleep study. So if they have cataplexy, then it's narcolepsy 1. If they don't have cataplexy, it can't be narcolepsy 1. It could be narcolepsy 2, or it could be idiopathic hypersomnia. There's a lot of diagnostic ambiguity between narcolepsy 2 and idiopathic hypersomnia. Some people will find that their diagnosis kind of flips back and forth between the two. But here's the stuff that you're going to see in both types. So, of course, excessive daytime sleepiness, that's a big symptom. Sleep paralysis. I think somebody had a question in the chat about sleep paralysis. So, what's happening here is it's the transition from REM to being awake. And it's like you're half awake and you're half in REM. So, your body's paralyzed because you're in REM, but you're awake. Like, and so it's kind of like this, because what's happening with narcolepsy, like kind of what's going on is that the transition between wake and sleep is not stable. And so you see a lot of stuff that happens at the transition between wake and sleep. So like sleep paralysis, if someone is having like a lot of that, people can have it on occasion, but if somebody's having a lot of like they're awake but they can't move, it's terrifying. What's going on is that their body's in REM, but their brain's awake. And it's like that transition, something's gotten messed up there. You can also have what are called hypnagogic, means as you're falling asleep, and hypnopompic means as you're waking up, hallucinations. So as they're falling asleep or as they're waking up, they'll have maybe they'll see stuff in the room. So this is also like if somebody says that they're having hallucinations. If they are only having those hallucinations when they're falling asleep or when they're waking up and no other time, then that's not psychosis. That's not psychotic, could be narcolepsy. So looking for if someone's complaining of a lot of sleep paralysis, if they're complaining of they see stuff in the room, they hear stuff that's not really there, and it's as they're falling asleep and as they're waking up. Because again, it's like that transition between wake and sleep. A lot of also nightmares are going to show up a lot with narcolepsy. So if you're seeing nightmares, but also some of these other symptoms, people with narcolepsy do seem to have the ability to lucid dream. or I don't know what accounts for that, but they seem to have the ability. That's actually something that we'll do with the nightmares because they seem to have the ability to like control their dreams as they're happening. So that's something you can do to try to address those nightmares. And then people with narcolepsy actually don't sleep that well. They're super sleepy, they fall asleep easily, but the sleep they get is kind of crappy. A lot of the time, they will report difficulty maintaining sleep versus idiopathic hypersomnia. They tend to sleep pretty well, maybe too well. So, how is this diagnosed? It's a sleep study and it's really involved. So, they're first going to have an overnight sleep study. They're going to want to rule in or rule out sleep apnea as a cause of the sleepiness. But one of the things they're looking for, this stands for sleep onset and then REM or rapid eye movement. So people with narcolepsy tend to go into REM very quickly. So they're looking for like, do they go into REM within 15 minutes or less of falling asleep? And I think if they don't see any of those sleep onset REMs, then it's not narcolepsy. Then we call it idiopathic hypersomnia. But if they do see at least one instance of going into REM in less than 15 minutes, then they come back the next day and they do this crazy thing called the multiple sleep latency test where you fall asleep and they wake you up 5 times in a row. I think they like you fall asleep and then I think they let you sleep for like 20 minutes and then they wake you up and and 5 times. And they're averaging how long does it take you to fall asleep every time. And if that average is less than 8 minutes, and they're looking for at least two of you going into REM within 15 minutes of falling asleep. So it's super involved. Another thing that can happen is to check the person, do like a lumbar puncture and check their level of hypocretin slash orexin. It's the same substance. It was named by two different scientists in two different parts of the world, and they called it two different things. So it's the same stuff. It just so happened that two different people discovered it and they gave it two different names. But hypocretin slash orexin stabilizes the transition between wake and sleep. And so another thing that might happen with this is they might check somebody, they might be checked to see if they're deficient in either hypocretin or orexin, because that can also indicate that they might have narcolepsy. Okay, and I think we're getting close. Just have a couple more slides, and then I'll get to the questions in the chat. So, if you rule out sleep apnea and you rule out narcolepsy, a lot of the time you're kind of left with this, what we call idiopathic hypersomnia. And idiopathic, just a fancy way of saying we don't know why. And so with this, of course, you're going to like daily periods of hypersomnolence. That's part of it. They're not going to have the cataplexy. They're not going to like stumble if they get really surprised or really excited. You're going to see really intense, like everyone has a sleep inertia. Sleep inertia is like just that feeling like you're moving through sludge. Most of us have it for some amount of time. When we first wake up, and it tends to wear off. It could be up to 20, 30 minutes. If it's lasting longer than that, people with idiopathic hypersomnia have like, it's like really significant. It takes them a long time. And they'll also like, they might stew and say really just goofy stuff, like as they're waking up. Like we call it sleep drunkenness. So that's another symptom. Also, naps. What's interesting, people with narcolepsy, their naps tend to be short and refreshing. We tend to recommend they take naps. Idiopathic hypersomnia, when they take naps, so these people they could sleep all day and all night and all the next day and just never feel like what I hear with my idiopathic hypersomnia. They're like, I just have to keep going. They're like, if I stop, I'm going to fall asleep. Their naps tend to be long and they tend to not be very refreshing. So I'm going to just to touch a little bit on, you might ask, well, isn't this just depression, or how is this different from depression? Because obviously with depression, you might see both excessive sleepiness and prolonged sleep. Of course, you can always have both. We can we can just collect as many there's diagnoses as you can certainly have both. Here's a little bit about how they're different. So, of course, with depression, you're looking for other symptoms. It's not just the sleep. And in fact, somebody could meet criteria for depression and not have any sleep issues. They just meet the other criteria. So, you're looking for mood, appetite, level, and then like all. Do they have all the other symptoms that signify depression? Also, depression often is more episodic. I mean, of course, there are people with certain people with chronic depression, but it tends to be more episodic. Idiopathic hypersomnia is chronic. If their mood's great, if their mood's terrible, this is chronic, day in, day out. Um, and also, finally, people with depression, they often are reporting pretty poor quality sleep. Um, Whereas people with they sleep pretty well. They fall asleep quickly. They do not wake up. They sleep long. They're not typically going to be complaining of poor quality sleep. All right, I think this is my last slide. But what is interesting is a lot of the behavioral tools for narcolepsy and idiopathic hypersomnia, it's a lot of the same stuff that we use for depression. So behavioral activation, that's a CBT, uh, um, not modality. What's the word I'm looking for? Method. And I'm sure a lot of you guys know what this is. I do it in a couple of different pieces. The first piece is to have the person kind of track what they're doing throughout the week and then track their mood. And then go back and look at, oh, okay, when I did this, my mood was good. When I did this, my mood was bad. How could we get like more of the good and less of the bad to the extent that we can? And then also kind of going over like the ideas of behavioral activation, that the success is in the effort rather than the outcome, that action has to precede the motivation. But so, yeah, it's a lot of the same stuff that works for depression. It will also be helpful for dealing with these kinds of disorders. Trying to find a balance of nurturing versus depleting activities. So, try to make a list of what do you do during the day, what's nurturing, what's depleting, how can we try to get more N's and fewer D's, again, to the extent that we can. For narcolepsy and idiopathic hypersomnia, it's helpful for them to think of they don't have one big day, they have 3 little days. So we break up the day, one long day, we break it up into 3 small days. And for narcolepsy, it's part of that is also scheduled naps. It's debatable whether I've heard mixed things about with idiopathic hypersomnia. Some people say naps are not helpful for them. Other people say we don't have any evidence that naps aren't helpful. So I don't know. We're kind of split on that. But for narcolepsy, for sure, little nap, like 10, 20 minutes. So you have like a morning chunk and then a 20-minute nap and then an afternoon chunk and then a 20-minute nap and then your evening chunk and then you go to sleep for the night. But one day is 3 little days. Talked about scheduled naps, and then it's just a lot of like because these are chronic illnesses and they can really disrupt. They can be very disabling. It's really hard to date. It's hard to, how do you date when you have narcolepsy? Like, um, so a lot of like just I would say mindfulness and acceptance kind of work, like accepting that this is a chronic illness. We are not going to cure it. We can give medication to try to help with some of the symptoms. We can work on some skills to try to help make your day to day better. But it's not like insomnia where you can get in and cure it and knock it out. This is different. Okay, I think that is all right. So I am going to go through and just look for questions. Yeah, I'm just going to scroll, and when I see a question, I'm going to stop and answer it. So I'm going to put I hate the daylight savings time shift. The American Academy of Sleep Medicine is advocating for us to quit doing it. They lobby Congress every year. They're never successful. So I guess the AASM doesn't have too much pull. I don't know, but because it is so disruptive to people's circadian rhythms, and so um they lobby every year. They've never been successful, but we'll see. And then I think I answered the question about like sleep paralysis that's happening kind of in that transition between REM and waking up. Yes, Sleepwalking. My brother did the same thing. He would pee in the shower, he would pee in the tub. So we kind of just with sleepwalking, really, you just want to try to make sure that they're not going to hurt themselves. It's not really harmful, provided they're not like tripping and falling or grabbing knives or anything like that. So a lot of like we would just kind of gently guide him back to his room. Um, are night terrors dangerous? No. They're horrifying for anyone who's in the house with somebody who's having a night terror. But no, as far as I know, they don't pose any sort of danger. Like the person that's having them, they have no recollection. They have no idea what's going on. Um, okay, yeah, and then yeah, walked out clearly still out of it. Yeah, I don't know what it is about peeing and sleepwalking, but so for night terrors, the treatment is it's scheduled awakenings. I don't have a lot of experience with it, but I think if you just Google like scheduled awakenings for night terrors, that should at least get you going in the right direction. But you track, like for a couple of weeks, you try to track like about what time of the night they're typically having the night terror. And then you wake them up. So it's kind of a pain. And then you wake them up like just before they're going into the time where they're having the night terror. How long before bed should you work out slash eat dinner? So eating dinner, like 2 to 3 hours is kind of the time that I've typically heard. Working out, the data is kind of all over the place. There's some that says don't work out too close to bed or you're going to mess yourself up, and there is other data that says work out right before bed and you'll sleep great. So that's there's a range with that. And then as far as like the eating a light snack, I would say do that about an hour before bedtime and do it if it's like more than a 3 hour gap. But would you say that nobody has a sleep need of under 7 hours? Yeah, for the most part, no. Most people, there are some people that are just short sleepers. Most people, it's going to be between 7 and 9. Most of us have a sleep need between 7 and 9. There are people that need a little bit more. There are people that need a little bit less, but they're outliers. All right, yeah, it's time to doom scroll. I hope I get good sleep tonight. Yeah, performance anxiety. Yes, getting out of bed does help. Yes, there's a lot of over controlled people develop insomnia. Let's see. Does the new dream have to relate to the nightmare? So you just have to change. I mean, yes. Like you're using the nightmare as the original source material, and then usually what people will do is they'll have the nightmare go up to the point where stuff starts to get bad. And then that's where they'll change it. So it does need to be at least somewhat related to the original nightmare. And then how do you regulate the physical symptoms when you wake up? Like I know in CBTN, we definitely teach a lot of like grounding kind of stuff. Yeah. And what if you were aware you were having a nightmare, but you can't wake yourself? Yeah, I don't know. I mean, I know that's definitely happened to me where it's like, I know this is a dream. And I'm like, and I'll even have these weird things happen where I'll wake up, but I'm still in a dream. I don't know, it's like Inception or something. I'll wake up, but I'm still in a dream, and then I'll wake like subsequent wake ups, but and then finally I wake up for good. And I'm like, oh my God, finally. Yeah, I don't know of any method for waking yourself up if you're in the middle of a nightmare. I'm actually kind of curious. Hold on. I'm going to make myself a note. I want to know. I'm going to research that. Can you wake? Because I know there's people that can like lucid dream. Okay. Can you wake yourself up from a nightmare? Okay. I'm gonna research that. If I find anything, I might like shoot an email to shoot an email to Sydney. Okay. Yeah, where does policy changes stand? I know some school districts. I feel like I've heard some school districts have delayed the start time. It doesn't really seem to be going anywhere. The breakdown sleep needs at each age. I don't have it. Like, I know there's a chart, and you might actually be able to find it if you just Google like sleep needs at each. I know there's a chart that I've seen. I think it's put out by the American Academy of Sleep Medicine that actually does break down like the sleep need for each age. So that might be an easy Google search. Let's see. Discuss change in, yeah, hormone. Yeah, I didn't have time. God, and that's like a whole other. I mean, I've definitely had women just get started on progesterone and their sleep problem goes away. So it's a huge factor. Let's see, do sleep disorders increase or decrease in certain times of the year? Yeah, I don't. I'm trying to think if I know of any. I mean, other than I could see like if you're in a part of the world where it's like light 20, like if you're in like Alaska or a place where it's like the sun never sets and then the sun never rises. I'm curious about that. Hold on, I'm going to make myself a note. Do sleep disorders? I don't know of anything off the top of my head other than looking at places like Alaska, like the Arctic Circle, places where there's like extremes. Sleep aids and meds cause memory. I've heard the same thing. I've heard that about like Benadryl, and then also stuff like like Ambien. Okay. Oh yeah, and then there we go. Someone posted. Yeah, benzos. THC is a sleep aid. We don't have good data on THC, I think, because it's federally illegal, and so we can't study it. I don't know. I've had some people say it helps. I think the reality is we just don't really know what it does to people's sleep. Starting always related to sleep apnea. No, not always. Like for sleep apnea, and it's tricky too. So you're looking for like persistent snoring, like loud and persistent snoring. There are people that'll snore on occasion, like if they're sick, if they're congested. The other tricky thing, too, and I'm kind of in the process of learning more about this, is sleep apnea. We're starting to learn that it presents differently in women, and women may not show up with a lot of the typical. Like, I'm actually scheduled in a few weeks to attend a training about sleep apnea in women because we're starting to see that it might show up differently um, in women. Let's see. How soon should someone remove a nicotine patch? 2 hours. So try not to have any nicotine within 2 hours of when you want to go to bed, and then don't. And then ideally don't have any nicotine overnight. How can we determine how much sleep we need? So you can track it. You can like track how much you're sleeping and track how you feel, because it's really the amount of sleep that allows you to feel good during the day. And if you undersleep it, you're going to notice. But if you oversleep it, like if you oversleep your need, it's kind of like you have to pay it back to the bank, so to speak. So you might have a night where you sleep a lot, and then the next night you sleep kind of crappy. So that might mean that you're oversleeping your need. Okay, yeah, about lucid dreaming, which enables. I don't about lucid dreaming. I'm still pretty new. Like I know like CBT not for nightmares, um, but I don't know a lot. I know that there's people are using it with people with people with narcolepsy, and I know there's stuff is out there. Um, Okay, are melatonin supplements harmful? So the tricky thing is that I think it's regulated. I don't think it's regulated as a drug. It's like regulated as a food. I may be wrong, but try to find if you're taking melatonin, try to at least because we kind of don't know what's in a lot of the stuff you buy at the store. Try to find something that at least there's a label that says USP. It's like the US pharmacopoeia or something. Supposedly that means it's met some kind of a standard. Um, but and yes, yeah, and melatonin can make your dreams more vivid for sure. Ashwagandha and magnesium. I'm hearing a lot about it too. I don't know of any. I don't know of any data. They don't tend to be the first things I recommend. I don't know that they're necessarily harmful, assuming there's no drug interactions. But usually not the first thing I'd recommend. And if you have insomnia, probably not going to make a huge difference. Okay. Okay. I think I got through all the questions. We're at 12:01. I'll send my slide, Sydney, I'll email you my slides. So if people want those.
Yes. Well, thank you so much. This was a amazing, phenomenal training. I learned a lot. I think everyone else did as well, based on, tons of questions, tons of feedback in the
Yeah,
chat.
lots of good questions.
Yes. Yes. So thank you so, so much on
I,
behalf of everyone. This was
mhm.
awesome. And I really, really appreciate it. And I know everyone does as well. I have put the CEU survey information in the chat for anyone who needs to get off right now. So please take that survey by February 20th. That's next Friday to get 3 hours of CEU credit. So please take that, and then we'll share the recording and the slides with y'all after. Um, and then thank you for being here. We'll stay on for a couple minutes in case people have other questions. But thank y'all for being here, and take the survey, and see you next time.
Right. Bye.